Thank you. Good evening, and welcome to Penn State Fayette. I am Dr. Joe Jankowski. I'm the Associate Professor here in Human Development and Family Studies. Once again, we're very blessed to be partnering with our community partner, Fayette County Drug and Alcohol, to bring this presentation to you. It is an awesome presentation. Was part of the presentation when it was held down in Connellsville High School several weeks ago. Wonderful information that I was not aware of. So to have this distinguished panel that we have here tonight, we are very blessed. We're very blessed to have these individuals in Fayette County because it's going to take all of us to make a change. But without further ado, I would love to introduce you to a friend and colleague, Jana Kale. She is the administrator of Fayette County Drug and Alcohol. Jana?
Thank you, and as Joe has said, we are so blessed to have everyone here willing to listen, learn, and participate in such an issue that is affecting all of us, whether it affects us directly or it affects somebody that we know or love. I would like to take this moment to let you know that this has been a process that has been in play for several months. We have been doing a series of these in the fall to get out to the communities to talk about local issues regarding prescription drug abuse. We decided to do one more community countywide forum to deal with this issue because the issue does not go away. We have been very happy to have our local newspaper do a series of articles on the different aspects of addiction, and prescription drug abuse is one aspect that leads into several areas of addiction. So we want to bring this into play. We're going to give everybody an opportunity, if you would like, to participate after the panelists have had their moments to discuss the issues from various perspectives. And I don't want to stand here forever, so I am going to turn this over to Mr. Mark O'Keefe, who's going to be our moderator for the event.
Okay, thank you very much. The event tonight is titled Prescription Drug Abuse, the Cost of Getting High, presented by the Fayette County Drug and Alcohol Commission. Our keynote speaker for this evening will be Secretary Gary Tennis from the Department of Drug and Alcohol Programs. And after he speaks, we'll have a question and answer session with our panelists, and then we'll open the floor to questions from the audience. First of all, though, we do have a number of public officials here that we want to acknowledge. We have Fayette County Commissioner Angela Zimmerly.
Hello, everyone. Hello?
Hello. Ooh, hello. Can you hear me now? Welcome to this evening's presentation. I want to thank our keynote speaker for coming here today to participate and to give us, share with us his experience and his knowledge that I'm sure is going to be very invaluable to share here with Fayette County. Tonight's presentation, obviously, as you all can see, says prescription drug abuse. But look at the words right underneath it. The cost of getting high. And that's the important part of, in my opinion, and the important part of this presentation is the cost of getting high. It's not just the cost to the family anymore, the immediate family. It's a cost to society as a whole. It's a cost to Fayette County. It's a cost on our government, operations and cost, on our economics, and on our social well-being. It increases crime. It increases the cost for us to operate our government, for treatments and programs. And it encompasses in so many ways, from one end of the spectrum to the other, how it can affect us on a social level. And that's why it's important that we all understand. First off, you got to recognize and identify the problem. But then it's much more than that. Since it affects all of us in one area or the other, we all have to be part of the solution. And that's the important part today, is to listen to all of these panelists here today and to not only say, yeah, we have a problem, and we've recognized what the problem is. But what are we going to do about it? Because it may only affect you in a small amount, maybe only you in a small amount, maybe you only 50% of your life, you 100% of your life, but it affects us all. So if we are all affected by the problem, why not all of us get together for the solution? And that's what's important here today. So let's not leave today with just saying, yeah, we learned a little bit. It's what are we going to do about it? Because remember, it's our neighbors, it's our brothers, it's our sisters, it's our family members, it's our fellow Fayette County citizens. So let's try to make the solution work. I'd like to introduce State Representative Pam Snyder.
Good evening. I too would like to thank the Secretary for coming to Fayette County for this important event. House Resolution 659 has been passed and it establishes a drug task force. The Speaker of the House, in conjunction with the Majority Leader and Minority Leader, picked 2 members of the House on each side to serve, and I have been honored to be one of those 4 members. So I'm here tonight to listen and learn so that I can carry back to Harrisburg what we might be able to do to solve this terrible crisis we have. You know, drug addiction did not become an epidemic in this country overnight, and we can't eradicate it overnight. But it's forums like this, and Angela is exactly right. We are all in it together, because whether it's a member of our family, our neighbor, a member of our community, it impacts us all, and we have to do something to stop this from happening, whether it's prescription drug addiction or what our young kids are doing. We must stop it. So I hope tonight we can all leave here knowing that we're going to continue to work toward a solution and stop this in our communities. And with that, it is my honor to introduce Representative Deb Kula. Oh no, I'm sorry, I messed up. Leave it to the Greene County girl to mess up. It is my honor to introduce your state senator for many, many years, and he's smiling because he's retiring at the end of this year. So a great Fayette County welcome for Senator Rich Kasuma.
Thank you, Pam. Thank you, ladies and gentlemen, for that warm welcome. Jana, thank you for putting this forum together, and thank you for inviting me here to participate and, as the previous speakers said, to learn and to find out more about the problem and the issues and how we can address it. Also, thank you to the panel for taking time out of your busy schedules to be here to address this issue that is of epidemic proportions here in the Commonwealth of Pennsylvania. Welcome to Fayette County, Mr. Secretary. We're pleased that you're here to hear our concerns and our issues. We've heard the term many times over and over again, it takes a village. And those words ring true here. I mean, this isn't just drug and alcohol's problem and their issue to solve, or this panel's or the secretaries, but it's all of our problems. It's each and every one of us. It's our community. It's the churches, it's the schools. It's individuals like each one of us. It's individuals like us that are elected officials. But I think most importantly, it's also about family. And it's about parents becoming parents again and laying down the law and just talking to their children and educating them on the evils and about the problems that may exist right now and what is happening in terms of our communities. There are people who understand the problem, but there are also people who don't understand the problem. They got their head in the sand, and as Angela said, this affects people from all walks of life. Young, old, race, color, religion, and financial background. So it affects each and every one of us. Some of the things we need to be doing, I think, on our end, and I think that the members of the legislature will agree, that we need to be doing more. We are rated very low in terms of the state, in terms of statistics, in terms of what we have been doing in Harrisburg and what we've been doing legislatively to bring about change. There are things we need to do, such as dealing with doctor shopping and pharmacist shopping. We also have to give police, firemen, and EMS personnel, and perhaps maybe parents and individuals, the access to the antidote naloxone. This is providing the situation where if there is a drug overdose and you have access to this, that life can be saved. It can be saved immediately. One of the other things that we need to talk about also would be that here in the Commonwealth of Pennsylvania since 1999, prescription drug overdose has gone up 89%. 89%. Pennsylvania has one of the highest cases of drug overdose. Prescription drug overdose in Fayette County is leading the way, and I don't think that's anything any of us are proud of. So it's going to take all of us to work together with this forum tonight, and as we move forward, we have to do what we need to do in terms of, I think, reaching out to our young people, because those are the ones that we gotta educate. Those are the ones that we're going to win over. Those are the ones we're going to convince just to say, stop it now. So with that, I want to thank you once again for this opportunity to be here. And at this time, I would like to introduce the state representative from the 52nd Legislative District, Deb Kula.
Thank you, Senator, and good evening to everyone. As everyone has indicated here today, I too want to thank Janet Kyle from Drug and Alcohol for setting up this forum and bringing us all together. This is a great opportunity for all of us to listen and learn, to listen to the people that deal with this every day, that deal with the problems in different aspects of life. Whether it's the district attorney or it's Dr. Riley or whoever it is, they all deal with this problem in a different way. So to listen to them as to what they see in their everyday life and how we can help them to solve this problem, because they fight every day to solve this problem. We need to help. We need to be there with them. About, I think it was 4 years ago, and I had talked with Secretary Tennis about this evening. There was a bill passed, and I was the prime sponsor of the bill, to expand the scope of practice of pharmacists. Right now, pharmacists can only enter into drug therapy management in an institutional setting before this bill. This bill will now allow physicians to enter into collaborative agreements with pharmacists to do drug therapy management. And I think Secretary Tennis will advise you that this bill will kind of look at who's prescribing drugs. You know, is somebody shopping for different prescription drugs, so that these pharmacists can interact and can be a part of the solution to this problem. I don't think there's anyone more trained as to what drugs can do and the mixture of drugs like a pharmacist can, because that's what they've been trained to do. And I'm sure Mr. Litza from the apothecary will be able to speak to that issue this evening. And a few years ago, we created within the House of Representatives, because we saw a problem within all of the legislature, and the Senate, the House, and the governor agreed, that we needed a separate department. We needed a separate department to deal with drug and alcohol. That their main job is to focus on the drug and alcohol issues. And we were able to do that, and we have been very fortunate to have a secretary that is dedicated, that is committed to working with all of us, with all of you, to come up with a solution to the drug epidemic that we're facing right now. And we are very proud to have here this evening the Secretary of the Department of Drug and Alcohol, Gary Tennis. Gary?
Good evening. It is an honor and a pleasure to be here. Thank you, Representative Kula, and thank you for your leadership, both on that important bill with the pharmacists and on your leadership and your support for creating this Department of Drug and Alcohol programs. People ask me, well, why do you need a department just for drug and alcohol addiction, dealing with that issue. Well, drug and alcohol addiction, we know the problem is worse today than it's been in a long, long time, but for decades, drug and alcohol addiction has afflicted 1 out of 4 families in America, in Pennsylvania, and in this county here. 1 out of 4 families. You all have come tonight. It might be more than 1 out of 4 who understand the suffering that occurs in those families as we keep it secret because of the stigma, because of the shame and denial that exists around the disease of drug and alcohol addiction. We tend to keep it secret. Those families that are dealing with the issue tend to suffer in silence. And yet, with this disease, basically, in terms of the resources that we've put to it historically, although Pennsylvania has done better than the rest of the nation, we still provide a fraction of the resources that this problem needs, and it leaves us vulnerable to an epidemic. The kind of epidemic that we're now seeing with prescription drug abuse, the kind of epidemic we're now seeing with heroin abuse, which is really at historically high levels today. Right now, nationally, we fund enough, we pay for enough treatment to treat 1 person for every 10 people suffering with addiction. Pennsylvania does much better, 1 for every 8. Now, one of the questions I had, I came out of law enforcement. I actually worked for the Philadelphia District Attorney's Office as a prosecutor for 26 years. The last 20 years I worked on legislation and policy, and our aim was simple. Like your district attorneys, who I got to meet this morning on the phone, our aim was to bring down crime and make our communities as safe as possible. And as representative doing the legislation for the State District Attorneys Association, which is what I did for 20 years, we pushed through a lot of tough law and order bills. They didn't work. We locked a lot of people up. We drove up our state and county jail populations to really extraordinary levels, but we didn't really have much impact on crime. And it wasn't until 1992 when I had the honor to serve, I was appointed by the old President Bush to be executive director for the President's Commission on Model State Drug Laws, that I reached across actually to the president of the Drug and Alcohol Service Providers here, Deb Beck, and said, tell me a little bit about drug and alcohol addiction. Teach me about that. And what I learned was, and this is to kind of follow up on the comments that were made earlier tonight, 70 to 80% of the people that are in our jails and in our prisons that we're locking up are there with untreated addiction. So the next question became for me, well then can we really do anything about that? As a prosecutor, when you're in the courtroom and you're trying case after case, what I would do is basically I'd be trying a jury trial during the day. At about 4 o'clock, the judge dismisses the jury, and I got what were called violation of probation or violation of parole hearings. These are people who were who were diverted into treatment, and if they got better, they never came back. I never saw them again. Everybody who had a problem, who didn't do well, all came back to me. So as far as I was concerned, it was a 100% failure rate. But then when I looked at the research, it showed that if we do treatment with clinical integrity, if we give these individuals the level of treatment, the amount they need, long enough and with sufficient intensity, with all of the case management, all the wraparound supports, we can reduce crime by 70%. 70% reduction in crime. And in Pennsylvania, it's even better. We do such a good job with our diversion program that there's going to be a study coming out, actually, that's been studied by Pennsylvania Commission on Crime and Delinquency. The recidivism rate, that's the reoffending rate for people who go into treatment, 16% 2 years after they've gotten out, at which point, for the most part, most people are home free, they're doing well. So 16% recidivism rate for the addicted, folks with addiction who are committing pretty serious crimes. For any of us who have worked in criminal justice, whether on the defense side or the prosecution side, those numbers are enough to make your head spin. Those are amazing, amazing recidivism numbers. So here we are. We talked about, one of our speakers, I believe it was our commissioner was speaking, county commissioner was speaking about the suffering that occurs, or maybe it was Representative Kula, I'm not sure, but the suffering that occurs within the family, the human cost. But picture if we were able to actually give them, everybody who needed it, the level of drug and alcohol addiction treatment they needed, and what kind of impact that could have if we can reduce recidivism by 16%. There is no question in my mind, as someone who has spent his entire life studying the criminal justice system and the last 15 years studying the drug and alcohol addiction treatment system, I am convinced that we can reduce crime in our communities by at least 50%. and we could shut down half of our jails and prisons. Safer communities, fewer prisons, fewer jails, and it would all be cheaper than the way we run the system now. We're here tonight, though, to talk about prescription drug abuse, and really, you can't talk about prescription drug abuse without talking about heroin. This problem cropped up, and for those of you who don't know, I may be telling you something you already know, but in the late 80s, early 90s, there was a very powerful movement in the medical community to say, you know, we can eliminate all pain. We need to make that one of the markers for successful treatment, that nobody needs to suffer any pain anymore. There's actually a very compelling article in the Wall Street Journal in December 2012 by the doctor, the charismatic figure who drove this change in our medical communities. And he basically told everyone, this addiction issue is overblown. Now he knows he probably killed hundreds of thousands of people with this mistake because he didn't bother to really research and look into the issue. What happened was suddenly prescribing over the last 15 years, the prescribing of prescription opioids has quadrupled in America. We're something like 4% of the world's population, and I believe we consume nearly all of the prescription opioids in America. So for many people, there are a couple of problems, a couple of issues why the prescription drug problem is particularly difficult. One, there's a sense of, well, particularly among our youth, high school kids, sometimes younger, among our youth, it's like, well, if doctors are prescribing it, it can't be that dangerous. So there's a sense that it's not as dangerous as the illegal drugs. Well, I have spent too much time with parents of kids who've died from prescription drug overdoses, or of kids who started out with prescription opioid addiction, and then moved to heroin, and then died, to be able too much time to not be able to tell you that that's just flat out wrong. These opioids are very, very dangerous. The other issue you need to know, and again, I think maybe it was the senator who mentioned it, everybody has different tolerances. Some people have the ability to take this and maybe be less likely to get addicted, but many people, because there's actually a genetic marker, many people have this genetic marker that makes them susceptible to getting addicted fairly quickly. And then what happens is the usual scenario, once you're addicted to prescription opioids, that addiction continues. There can be drug-seeking behavior then to try to get more of them. And ultimately, as left untreated, the addiction continues, it gets worse, and then sooner or later, the person starts going for heroin because they can't afford, maybe their lives have fallen apart, maybe they've lost their jobs, maybe they've sundered their relationships with their families, and the constant quest to try to avoid that terrible sickness that comes when you quit. So this is kind of the scenario we have. There are many ways that we're trying to address that with the problem. I think Representative Kula's legislation that she got through is going to be a big help. We have prescription monitoring program legislation, and that legislation is now over in the Senate. There are a couple of bills that have gone over to the Senate. Both bills are excellent. We need them badly. Every state that has passed a prescription monitoring program bill has found a strong impact on reduction on the number of new people getting addicted to prescription opioids and other addictive prescription drugs. Another thing we've been looking at is, well, how do we change up prescribing practices? And one of the things we did, some states have really been working on this issue, and we have actually, the Corbett administration has directed me, and we've pulled together doctors from all over the state. We've had 2 kind of marathon meetings, and a week ago, this past Monday, we actually settled on our first draft of the Pennsylvania prescribing guidelines that we're sending over to the Medical Society. We're going to be sending it over to the Joint State Government Commission that's working on the issue, and we think these guidelines are going to have a big, big impact on prescribing. They're based off of what was done in Ohio and implemented about a year ago. We think they're even a little bit stronger, and we believe, based on what's happening in Ohio, that they're going to reduce the number of new people getting addicted. So prescription monitoring programs, prescribing guidelines for doctors are going to make a difference. The other thing is we have a take-back program, and I was having a good discussion with your district attorney about exploring the possibility of these. We have these available, and we've been placing them around the state. One of the things we know is that Sometimes our adolescents will steal these from medicine cabinets. And they take them, they think these are going to be fun to take and see what happens. Sometimes the combinations are lethal. Very often it ends up with individuals getting addicted and then having their lives deteriorate. By the way, just so I'm 100% clear about this, left untreated, drug and alcohol addiction progresses, it's always progressive, and it will always be fatal if it's left untreated. You might end up and have a few passages through the criminal justice system on your way to an early death, but it is a fatal disease. It needs to be treated. So this is very, very serious, and I'm sure all of you in this room today wouldn't be here if you didn't already know that, but I just want to underscore that that is the case. So we're working on the take-back program, the prescription monitoring program. There are other innovative ways too. We're trying to get more in a time when there are scarce resources, because we're still coming out of the Great Recession, but we're trying to find ways to bring more resources into treatment. One of the ways we've looked at is looking at individuals that we divert into treatment at sentencing and seeing if we can save the county's money by putting them into treatment within a couple of weeks of arrest instead. There are all kinds of advantages to that. The individuals don't get kind of inculcated in criminogenic thinking by being in the county jail. They're more highly motivated to do well in treatment because they're looking at a sentencing, and we save dollars for our counties, and those are dollars that we're asking our county commissioners to then use to fund more drug and alcohol treatment. Some counties, I'm looking at Colleen Hughes in Westmoreland County, they were already ahead of the marker, already doing that, but we now have 7 or 8 more counties added to it, and that's something that we're interested in trying to do everywhere and across the state. Just to kind of highlight a few little facts about this, right now, today, in the year 2014, 3 million teenagers this year will become new prescription drug abusers. 3 million American teenagers. This is a big issue. I've talked about access to treatment. The Governor's Healthy Pennsylvania program, which if it's accepted by the federal government, and we're optimistic that that will happen, will treat those with drug and alcohol addiction as medically frail, and will put them on Medicaid. Not in the private choice option, but on Medicaid. And our Medicaid benefit, because of legislation I'm pretty sure Senator Kucinich voted for a decade or two back, has a strong drug and alcohol treatment benefit. That will be a dramatic expansion in access to treatment in Pennsylvania. So this is a critical issue. I often refer to drug and alcohol abuse, whether it's prescription drug or heroin or alcoholism, as an invisible giant that causes extraordinary suffering in our communities and drives costs across every department in our state and drives costs in every one of our counties. Your commitment in showing up here tonight is the kind of commitment we need to begin to really develop rational policy in drug and alcohol and really address this problem with all of the forces that we can muster. I want to close because stigma is an issue. I want to just talk a little bit about stigma and how much it affects how we think about drug and alcohol abuse. There was an article in the Philadelphia Inquirer, and this is kind of burned on my memory. It was an excellent article about the overdose problem that's occurring, and it's not just here, it's everywhere. And the first comment on the blogs that occurred, this is kind of the underlying attitude. It said, and this is a little shocking and sickening, it said, overdose is nature's way of taking out the trash. That is the kind of attitude, that issue of looking at this is a way that individuals suffering from addiction is because they're bad people, that it's really time for us to move beyond. One of the signers of the Declaration of Independence, one of our Philadelphia residents, Dr. Benjamin Rush, nearly a quarter of a millennium ago, 250 years ago, was the first one to see they had terrible alcoholism problems in colonial times. They would put people in stocks. They tried to find one way or the other how to punish them out of their drinking problems. 240 years ago, Dr. Benjamin Rush said, maybe this is the wrong paradigm. And looking at this as a doctor, I think this is a disease. We need to treat this as a disease and stop treating it as a moral issue. And it began a process that still goes on today. Still, in the city of Philadelphia, where Dr. Benjamin Rush lived, We have this stigma. It's time to let the stigma go. Although there's certainly personal responsibility in getting better from this disease and getting into the disease, as there is with heart disease and many other diseases that are caused by bad behaviors, we owe it to ourselves, we owe it to the families, we owe it to our pocketbooks, we owe it just from one human being to the other, that we really take on this disease and treat this disease as we would any other, and make sure that those who are in need of treatment get the treatment they need. So thank you so much for listening to me. Thank you for showing up here tonight. And I think you've got a very prestigious group here, and I look forward to hearing what they have to say. Thank you.
Okay, we wanted to introduce our panelists for this evening. We have pharmacist Walt Leza, Fayette County Coroner Dr. Philip Riley, Steve Contaxis from the Fayette County Drug Task Force, Attorney Jack Purcell, District Attorney Jack Hennix, Dr. Robert Woolhandler, Treatment Clinical Elaine Staino, and we have two recovery people, Bill and Brandon. So we do have a number of questions for the panelists, and the only thing that I would say is try to be as brief as you can, because we do want to give everybody, all the panelists, the opportunity to speak, and also too, we do want to have allow anybody in the audience that has any questions, and we want to try and get everybody home at a decent time too. Thank God there's no pens on tonight or anything, so we can all rest easy with that. But and I don't have a cane or anything like that, but I do have a clock here, and I'll be watching it. So just urge it, 2-3 minutes. That'll be more than enough. So we'll start out. I'll be asking the questions, and we'll go around to the panelists. First question is for Walt Leza. What is a prescription drug, and are they harmful?
First of all, I'd like to thank Fayette County Drug and Alcohol for having me on this panel. I feel honored to be with such distinguished people on this panel. Secondly, I'd like to thank Representative Kula and her fellow legislators for supporting so many issues relating to pharmacy. Trust me, it doesn't go unnoticed. We do appreciate it. So thank you very much. As far as a prescription drug, it's quite simple. It's a drug that requires a prescription. Really, that's it. Well, it's not very difficult. But the things that go along with it are, there are different schedules to drugs. There are non-scheduled drugs, which are the more common ones, drugs that are used for diabetes, high blood pressure, epilepsy. Then you have these scheduled drugs, which go from Schedule 2 through 5. The lower schedule, starting with Schedule 2, are drugs like oxycodone, OxyContin, move on to all the way to Schedule 5, which are some of the codeine-containing cough syrups and things like that. The lower the schedule of the drug, the more addictive its potential is. So, if taken properly, are these drugs dangerous? No, they're not. If you're taking a medication for the appropriate reason and taking it properly, you should have no ill effects. Obviously, everything can have a side effect, but are they dangerous? Truly not. Now, when you don't need a medication, and let's say you are taking it more for pleasure, obviously it's going to require higher doses. Can those cause problems? Absolutely. Can it cause addiction? Absolutely. They can cause difficulty in breathing, respiratory depression. So, is it an issue? No doubt. As Secretary Tennis said, just small amounts of medications can cause problems with people because they have an addictive potential themselves. Because of their biological makeup, they're more apt to become addicted to a drug than somebody else. We've actually seen people who are elderly that go through a knee replacement or a hip replacement. They're on a medication for a short period of time, And then upon discontinuation that medication, next thing you know, they're going through the delirium tremors, and they're starting to have withdrawal effects. So can it happen quickly? It can, absolutely. So are they dangerous? Once again, if used correctly, should have no ill effects. When they're misused, very, very dangerous, as to which I'm sure you're going to hear from our fellow panelists.
Okay, thank you very much.
Can I ask a question? Ask you a question.
Sure.
Walt, could you talk about tramadol and why it's not controlled, even though it's an opiate?
You know, truthfully, doctor, I don't know why it's not controlled. To be totally honest with you, it should be. I'm a big believer that tramadol should be a scheduled drug, and also I think hydrocodone should be a Schedule 2 instead of a Schedule 3. Why things are scheduled the way they are, it's beyond me. Another good one I can give you is, if you take a look at Furanol, which is used for headaches, it's a combination of butalbital, aspirin, and caffeine. It is considered a scheduled substance. If you take a look at Furacet, which is a combination of butalbital, acetaminophen, and caffeine, so the difference is only Tylenol compared to aspirin, that one is not scheduled. Well, neither aspirin nor Tylenol are addictive. What on earth would make the Furacet not scheduled? The rationale is beyond me, truthfully.
And that's another one. And the reason I bring it up is because so many times through my practice day to day, people come in and they're on tramadol. The doctors told them it's non-addicting. So I want people to be aware of that it is addicting. It is essentially acting opiate. This goes to some of our work about doctors need education. Doctors get very little education on drug and alcohol. Went through education a long time ago. When I talk to the young guys, they get as much as we or less. So a lot of times when a doctor tells a patient, well, it's not addicting, when it actually is addicting, that's why I just wanted that word to be out there. Tramadol is an opiate.
Yes.
Beware.
Okay, thank you very much. Our next question is for Dr. Riley. What are the most commonly prescribed medications that are being used for pain management?
Well, thank you for the opportunity. If we're looking at pure pain from whatever cause, an old standby, well, Tylenol with codeine. Tylenol didn't mean that much. It's very mild for pain, but it's a codeine, and it's been used for years. It hasn't led to a big addictive problem because very few of us would take a lot of codeine because you get sick. We've all had codeine cough syrup, and you get a queasy stomach and nausea, so it never really evolved. Problem was it didn't have the potency, so that we moved up to the short-acting, fast-acting hydrocodone. And I even put that in a cough syrup, and it really works for cough, really works. But it's addictive. It's a narcotic analgesic, and the nuisance factor, it may last only 4 hours, maybe 6. You'd like to see it last 8. So they were looking and searching for this poor person that has this pain from terrible fractures, and it's only going to last 4 hours. We're treating this round the clock, 4 times a day and so forth. So couldn't we invent a long-acting? And we did. The OxyContin combinations that last 12 hours or so. And that's nice convenience, twice a day dosing and so forth. Very potent, taken at the right dose, and clearly at every 12 hours and not more, you wouldn't get into trouble. But imagine if you took an extra one, whether confused, forgetful, or just didn't think the first one worked. You're now dealing with a 12-hour delivery of medication shingled onto it, so that carried with it a convenience, and the downside, this immense threat of a potential error and overdosing innocently on that. Whether I had terrible pain for my hip, or if I were looking for a high, not using it illicitly because I had the source. So then we thought, well, we're even smarter. We'll come up with a patch, and a patch that had 72 hours of continuous pain suppression with high blood levels of a narcotic analgesic that was first invented as an anesthesia agent to put you out for surgery. Fentanyl, correct, Walt? Correct. And here you have that, and it took us a while, and what saved us was the media. It turns out that 72 hours, someone looking for a high would bite into the patch and suck through the whole patch gel out and have 72 hours of narcotic analgesic in the system in minutes, and frequently would be dead by the time they would hit the floor. So we only recently wised up, that's ridiculous, but when we had the clusters of deaths from the fentanyl patches, the media helped us out, pointing out the danger, and the illicit users got smart and stopped doing that, knowing that it's so powerful, and the industry within the past year designed a patch. Can't happen. Correct, Walt? It delivers it out, so we have those 3 levels of pain. Tylenol with codeine, safe, may not handle all your pain. The short acting, we have the nuisance, but it doesn't have the threat of an accident. That the long-acting 12-hour pills, should you innocently take an extra one, and this is where, again, we would turn, however we get the message out. Convenience has a built-in serious threat that we're accepting that convenience of dosing. Imagine passing it out with 100 patients in a nursing facility. Now you only pass out twice daily, the manpower issues and so forth. But we pay a price, and we will see inadvertent deaths, whether it's an illicit user or authentic pain. The patches may come down the road to solve the problem in being, in a sense, foolproof. So the patch is on, off, and then a new one goes on in 3 days. Obviously, if you put 2 patches on at the same time, or 3, we're looking at a potential for death. But those are the common painkillers. Tramadol's in that group. I don't know that I've never told a patient that you can't get addicted on it. It just has a little better safety. It's not used rampantly than throughout because it's not that good. Is that true? It's just not that great as a painkiller. So fortunately, we don't have to deal a lot with the tramadol.
At the smaller doses, yeah, you don't tend to get the euphoria with it.
Yes.
But at the higher doses, yeah.
Yes. And so it's not surfacing as a real problem that it had to deal with in death so far. It could happen down the line.
I have a question.
But thank you.
What would be the most commonly prescribed medications for pain management that's not opiate-based? Are there many? Are they effective?
Well, and they advertise as painkillers, and that's all of your non-steroid anti-inflammatories. The beauty of them, they're really getting to the heart of the problem, an irritated nerve or a smashed toe or something like that. And that's our Levin, our ibuprofen, and they will alleviate your pain, and they help and are adequate for many people with injuries or whatever. They'll take care of the pain. They have side effects, and they have to be cautiously used, and even at the regular doses, they have the potential for irritation in the digestive tract, and even a potential for bleed, and they're very hard on the kidneys. But they wouldn't be abused for pain because you get the other problems would surface with them if you overuse those. But even at their recommended doses, they're a little tricky. We have to be careful with them.
And there are other ways of dealing with pain. There are other things doctors can do. There are these TENS units, which are the electronic stimulation units that are effective dealing with pain. There's physical therapy. Even cognitive behavioral therapy can teach you to live and not have your life compromised by certain levels of pain. There's a difference between pain and suffering. And they found that certain kinds of counseling can also have a big impact. So it doesn't always have to be a pill. It doesn't have to be something that you're taking. Acupuncture sometimes can be effective. There are a number of different ways of addressing pain, and some, as the coroner said, is really go more to the root causes rather than just suppressing the symptom.
Even acupuncture.
Yeah, acupuncture. I can add a couple other. They are using some of the antidepressants like Cymbalta, Elavil, and they can be helpful with some pains too, and some of the neuropathic pains too. Yeah, Neurontin. So we have to watch Neurontin now because we're starting to feel Neurontin can be very addictive too. So it's also, you have to be careful with the medication Neurontin. And the antidepressants work by blocking or inhibiting the pain sensation getting up to the brain. And so they're always worth a try. And I agree with these doctors over here that when we have a chronic benign pain situation, we cannot use opiates because it's going to be a disaster. And that's what we have to re-educate doctors on more and more, is how they can treat chronic benign pain in ways. And I don't know if we have any in this state, but some of the states already have non-opiate pain clinics where they work with a lot of those techniques. Everything that we've talked about here today, trying to stay away from the opiates, because that's usually a one-way street.
Another interesting footnote to this part of the conversation is in the same period of time that you were talking about from 99 to 2010, with the 89% increase, I think you said 89% increase in opioid analgesics, the non-opioid analgesics, the NSAIDs and the others, actually were prescribed a little bit less in that same period of time. So there was a reaction towards the opioid pain medications and away from the non-opioid pain medications.
Okay, we're going to move on to the next question for Elaine Stana. How is heroin related to prescription drugs?
Hello. First, before I answer the question, I want to thank Mr. Tennis for being here. It was so refreshing to hear your understanding and insight of addiction. I truly appreciate that, and I felt very confident in knowing that you agree with a lot of what we talk about with addiction. So, thank you. Okay. Heroin and pain pills. I think it's not a secret now that we have shown that a lot of people are being introduced to heroin because they were first introduced to pain pills, and because the cost of pain pills are so exorbitant on the street. And there's some very good marketing people out there for heroin, and heroin has gone down in price. I think it's just common sense to anybody who's addicted that if I can save myself a few $100s using heroin as opposed to pain pills, well, then that's just what I'm going to do. I think also the idea that heroin doesn't have to be injected, although that is something that every addict I think I've ever met has stated, I never use IV. The fact that you can snort it has given it a lot more acceptability among people. What prescription pain pills have also done for heroin is it's developed a new market. Because in the past, most of the time, heroin, because it is an illegal drug, is only really used among people who are looking for illegal drugs. Now you have individuals who have a bona fide addiction to an opiate, and they want relief, and so now maybe some of the coworkers that they have been introduced to heroin to help them with their pain, and they see nothing wrong with it. So I agree with Mr. Tennis. The idea that the prescription drugs are not as dangerous as heroin still holds true. And the difference between people now who come in with opiate addictions is that we start to see people that are more middle-aged, people that are working people, people that have never really thought about using a chemical to get high. They were introduced that chemical to aid them with a problem. And when they found themselves addicted, they found very few places they could go for help. Because most of the time, in the medical community, when you become addicted, they do not want to continue to treat you. Thus, you have to find another way in order to get help. And sometimes that does result in buying something off of the street. So prescription painkillers has helped the heroin usage in our country right now.
Okay, thank you very much. Our next question is for Dr. Woolhammer. What is addiction?
Why does Dr. Riley get all the easy questions? Well, okay, addiction is a lot. I mean, it's like we could talk for hours on what addiction is, but I'm going to sort of give you 3 or 4 ideas about what addiction is. One of the best definitions I've heard of, and I remember this, I don't know if people are familiar with this, they're called the Joe and Charlie tapes, or 12-step tapes, and they described addiction in there as, once you start, you can't stop. Once you stop, you can't stop restarting. And you get into that cycle. And that is one of the best definitions I've ever heard of addiction. If you read some of Dr. Torsky's books, he uses a very simple definition. He said addiction is the use of drugs in spite of negative consequences. So if someone drinks, loses their job, and they continue to drink, got to be addiction. The other thing he talks about a lot about is addiction is a sort of a disease of escapism, leaving reality. And all the therapy we do is mostly having people learn to deal with reality. And it's not easy to have to hug reality day after day and deal with it. We were just working with 2 or 3 people today that were just really struggling with their early recovery because they're dealing with things they just didn't deal with. They would just get high and move on to the next drug. But if we get down to if you want to look at the physiological level, when I write the diagnosis on someone's chart as like opiate dependence, that means 2 things. One, they are physically dependent, and by physically dependent, I mean that when they stop using the opiate, they'll have physical withdrawal symptoms. Because we all know those: nervousness, running bowels, anxiety, restless legs, all over the place. So when you give a drug to someone and it produces an effect, opiates actually produce the opposite effects. They're constipating, they produce euphoria, they calm a person. When they stop it, the opposite happens. And that goes with any drug. You want to look at any drug that's addicting. Whatever it does for you when you get high, the opposite will happen to you when you stop the drug. So that's the physical dependence part. And you can have that and not be an addict, because you have to have the other part, which is the psychological dependence. And that's a key one. That's when people have the cravings. They are unable to stop using. They are able to stop, but they can't stop restarting. And the cravings and the triggers are powerful. They'll be clean for 2 or 3 weeks, and they see a friend across the street they used to get high with, and bingo, there's this tremendous craving to use opiates. So that you have to have both parts. That's the pure definition. I still like the one Joe and Charlie say, because it's down to earth, simple. Once you start, you can't stop. Once you stop, you can't stop restarting.
Okay, thank you very much. We're going to go back to Elaine for the next question. What does an addict look like, and what's the difference between the stereotypes and the reality?
Well, what does an addict look like? All you have to do is look to the person beside you. That's what an addict looks like, just like everybody else. I think there is those stereotypes that depicts the addict as the person who is slovenly dressed, or the person who is filled with tattoos and has all kind of piercings everywhere. And these are the person who, or the people who don't hold down jobs, and they don't really have any respect in the community. And they're people who just have no value system at all. And we know now, in working with a lot of the people that we work with, they're like you and me. They are just like you and me. They got caught off guard with addiction. I know the forum is about prescription drug use, but let me just say that in the years that I've worked, my working with addicts was always generally with people who their intention was to get high. That's how they ended up in treatment. They wanted to get high, their brain clicked, they ended up addicted. But now we see a lot more people who did not start out with an addiction because they wanted to get high. And that is a big, big difference between the addictions that we see now with opiates and those that we saw with with heroin. These individuals live in shame and guilt every day of their life because they don't understand how they ended up with an addiction when they were just doing what they were told to do. So if you want, again, you want to identify who the addict is, it's anybody who allows themselves or who's prescribed a mood-altering drug, who does not pay attention to how often and how long they're using it. That is who the addict is today.
Okay, thank you very much.
Just one comment I want to make. I think Elaine hit the nail on the head. It's very easy to become addicted. You know, and I've learned this years of law enforcement, and I see the people out on the streets. And, you know, if there's one message that we can get across to young people, is to try to teach them, number one, how easy it is to get addicted, and number two, what happens to you after you're addicted. And, you know, we see a person, and we talked a little bit about the path from the prescription pills to the heroin. Let me just tell you, that's a very short path. Because very oftentimes we see a person, you know, they might get arrested for prescription pills. Next thing you know, not long afterwards, you know, we're arresting them again for heroin. It is a very short path. And what people are looking for, you know, they got that first high. Then from that point on, it's always seeking, okay, how can I get high? What is the next high? And that always leads to the heroin.
Let me add just one more piece to that. And I kind of got most of my education learning from folks in recovery who've really been through, and that's, I think, they're my best educators. What I heard over and over is how that first high was something you wanted to go back after you get, and it was this euphoria, this wonderful feeling. But the whole thing kind of just keeps ratcheting down, and pretty soon you just don't get that euphoria anymore. All you can do is avoid being sick. So you're either really, really sick, and now you're using just to get back to normal. And the whole thing, it just kind of ratchets down, and it's just kind of it seems like people, and actually suicide rate, unfortunately, is very, very high in the individuals who don't get, it's overdoses or suicides, basically, pretty much. And it's because life just gets to be so miserable, I think, after that.
Can I say something? You're correct. In the beginning, in the development of an addiction, it is about trying to trump the first high. But please understand that once you are in the addiction, it is totally different. Because addiction is a relationship. And I don't think most people understand that. They think addiction is I take a pill and I get a good feeling. But you talk to any addict and they'll tell you they ain't feeling so good. It becomes a way of life. It becomes what they live and breathe for and live with all the time. It is not the high anymore. Once the addiction sets in, it is not about being high. It's about learning how to function day by day the best way you know how now with an addicted brain.
Is there time for me to make one quick comment on this? I just wanted to repeat something Dr. Woolhandler said, that the idea of addiction to the point where it creates significant problems in one's life is very significant, because, I mean, you can be addicted to caffeine, but I've been to several rehabs and I've never been in rehab with anybody who was there for caffeine. So that is kind of a point of differentiation where technically an addict, a caffeine addict is an addict, but you know, their life is not affected by that immediately. So that is a very significant quality of, you know, addicts who go to rehabs.
Okay, real quick. Okay. I wanted to just mention a little bit about the initial high. We think that's part of the brain chemistry, that not everyone experiences that, but the person that's probably going to go on to be an addict is the one that's going to experience that tremendous euphoria. Like you said, they'll be chasing that sometimes the rest of their lives. But that seems to be part of the, I didn't get a chance to talk about that in my part, left it out, but about the brain chemistry being, there is a brain chemistry difference in addicted person and the non-addicted person. And so I'm not going to go into much more of it because we've got time factors here. Thanks for that.
Okay, thank you very much. We're going to move on to the next question. This will be for Dr. Riley. How big of a problem is heroin in Fayette County?
At the present moment, there's not a surge of heroin here. We're seeing mostly the overdosing on and overuse of prescription drugs when it turns out to be a death. It's still worth knowing where the surges are, because if it's the illicit drug source, then we can gear up and alert the investigatory agencies and the drug task force to interdict and so intercept and do what they can. On the other hand, if this surge comes in the prescription medications, then as we're now alerted, that we have to look at it from what can be done from the source of the prescription drugs. So the surges will come and go, and I can predict fairly accurately that where the surge at present is the prescription drugs because of accessibility. There's plenty of them out there. They're not inordinately expensive. When that's either supply or the expense goes up, the surge will be to heroin, which is stunningly inexpensive. Multiple doses that can be secured for a minimum amount of medication. The one aspect that out of fairness you ought to consider is that almost in the celebration, prescription drugs have outnumbered the number of deaths from the illicit drug sources. Well, where do prescription drugs come from? Well, they come from the doctors. Well, then the doctors must have got us into this pickle, and now we'll better get after the doctors and get them to fix the pickle. And whether it's by mandating how they should manage their treatment, or whether they go to additional education, which is certainly available. There are online programs, there's mandated courses, and they're getting even to down to the level of the med students. So, but you have to consider not me as coroner, but as a practicing physician, take for a moment and think about this. You walk into that office, there is a measurement in your body that I cannot measure practically and fix. Your lipids, we can get those fixed in a couple months. Your magnesium level, your blood sugar, we can get that fixed. If Walt comes into it and he dropped a 16-pound bowling ball on his toe and he has big alligator tears coming out his eyes, I haven't the foggiest idea how much pain he has. I know mine. If it was my bowling ball, it's the worst pain in the world imaginable. My toe, I have no idea how much. The physician has to take it at face value, and as cautiously possible, treat the pain. If Walt came in because he spilled his charcoal lighter on him and has half the skin burned off his body, would you want something for pain, Walt? And in 3 days in an ICU unit, he can be addicted to IV morphine or whatever we use because it's in the system 24 hours at massive doses and all, and now we have a major problem and he has to be weaned. So consider, pain is a real thing, unmeasurable by anything. We had mood rings trying to measure pain. West Virginia University had forehead patches. We can't tell when you come through that door, and we want to do the best we can in the most cautious way we can. Can we legislate accurate medical care? You can't legislate how well I treat your lipids and what I use for you. So give us a little bit of sympathy on this, that the surge is now, the big thing is the prescription meds must be traceable to the docs. They should be helping us fix it. It's not quite that neat an issue.
Well, let me just advertise our prescribing guidelines, and these are guidelines. In Ohio, they have a prescription monitoring program in Ohio, and they implemented their Ohio prescribing guidelines 12 months ago. The number of hits on the prescription monitoring program went up 8-fold in 12 months. Just raising the level of consciousness, teaching doctors certain basic things like, do you have a history of addiction? Do you have a family history of addiction? Certain areas, even if we have the prescription monitoring program, the doctors will be able to check and see if the person's doctor shopping from one place. The other thing that I think was mentioned aptly is we need to increase training in addiction in our medical schools. And we have the good fortune of having a very strong federal regional director of this SAMHSA, the Substance Abuse Mental Health Services Administration. And I'm going to get the chance to meet with the deans of the medical schools in Pennsylvania to try to push hard There's only one medical school in all of Pennsylvania that has a mandatory course on addiction, University of Pennsylvania. None others have it. And many doctors, when somebody comes in, like one of the things I don't want to see with the prescription monitoring program is if somebody comes into my office engaging in drug-seeking behavior, if I just point to them and say, get the hell out of my office. Because if that happens, if everybody does that, then they're going to turn to heroin. Because these are people that are suffering from addiction. Our doctors need to know how to screen and how to refer somebody to specialty care. They know whether you've got a very, and one of the best SCAs in the state here with Jana Kyle, you need to know, the doctors here need to know where to refer somebody. If they're not an addiction doctor like you are, they need to know where to refer somebody to specialty care, to how to get them the help they need. Most doctors just don't know what to do.
And you're right, because it's incredible that there's only one school that has one course that's mandatory, and when those doctors go out into practice, 10 to 15% of people through their office every day are going to be drug addicts, alcoholics, or potentially on the way to that. When I ask doctors a lot, I don't see any addicts in my practice, because they don't know how to look for them. You know what I mean?
They don't know when they see them.
Exactly. So it's sort of like back to that basic education for physicians, which has been minimal. So like you said, they go the other way. They just get rid of them, avoid them, dodge them because they're going to be trouble, or steal scripts. So they never get either diagnosed or it's suspected. They just get shoved out. So
a management disease that affects 10% of the population, 1 out of 4 families, and we don't even have a course in it.
Yeah.
In virtually every medical school in the nation. So one of the things I came out of the criminal justice system. Coming into this world of drug and alcohol addiction policy, I feel like I've entered this Alice in Wonderland world where we just don't seem to be able to think straight for the life of us. This is another example where we just don't take the necessary steps. Now, I will continue to push on this. To me, this is another example of like low-hanging fruit. Let's teach our doctors enough so that they know what to do with our individuals. Doctors, I know, get frustrated. I've asked them, why do you get so mad about it when you do have somebody doing this? And basically, Dr. Matt Herford, who works in drug and alcohol issues in Philadelphia, said, doctors are trained to solve problems. We don't know how to solve this problem, so we just want them to go away. Just get out. So we need to teach them how to solve the problem.
I would like to briefly add to that. With the difference between heroin and the prescription drugs, there's a very distinct difference, and I think it's important to highlight it, and it's important to have panels like this and talk about the prescription drug problem, because in these numbers are from the CDC from 2010. Of the 38,000 drug overdose deaths in the United States in 2010, 60% were related to pharmaceuticals. Here's the thing. The reason why the pharmaceuticals are almost, in a way, more insidious than heroin is because of, number one, they're plentiful, they're cheaply made, they're safe. In the mind of a drug addict, you would much rather, trust me, take something out of a pill that has somebody's name on it that was prescribed by a doctor and made by a pharmaceutical company than you would buying something in a little bag that you don't know what it is. You're also much more likely to run into pharmaceutical grade drugs in schools than you are to find, not that you won't find heroin in schools, you will, but you're much more likely to find heroin in schools. I think when you look at the numbers, like you were talking about, the 89% increase, that is a direct correlation to the amount of prescriptions that have been written, and that, when you're talking about this, you're talking about supply side economics. When you create a market for something where it's cheap and plentiful and easily accessed, the problem is going to follow.
I agree with that totally. By the way, just another statistic along the line that you're talking about, prescription drug overdoses and abuse does now exceed all of the illegal street, all of them put together. But the other thing is now drug overdoses now as a cause of death now exceed car crashes as the leading cause of accidental death in America.
40,000 a year.
Yep.
Just to get a perspective on that, if you think about how long, and I'm not making comparisons between the reasons for the deaths, but if you think about how long we've been fighting overseas and how many people have died compared to how many people have died right here at home from drug overdoses, it's staggering difference. It's about 400,000 people in the last about 12, 14 years. right here in this country.
Secretary Tennis, yes. One thing I want to mention, and no one seemed to address this right now. As pharmacists, I can tell you, drug seekers, they're sneaky. Okay? So, they will go to a
can attest to that.
I mean, and they're sneaky. I mean, and they will sell you whatever you can imagine to make you believe that they are in dire need of something. They will make a doctor believe anything, okay? Because they've been practicing. So they will go to a doctor, and a doctor is there to help that patient. That doctor, in his mind, is trying to help alleviate whatever problem that patient has. Unfortunately, the doctor doesn't know that patient A is also going to Dr. B, C, D, E, and F. Okay? We in pharmacy have been trying to push for the monitoring system for years. Right now, there are 40 states that have it, and we don't.
48.
Okay? Well, now it's up to 48? Okay. So, as you can see, if they go to the monitoring and a Dr. A writes for the drug, and now all of a sudden the patient goes to Dr. B is going to see that they already went to Dr. A. Now all of a sudden, wow, now we can track it, now we can stop it. It's not just a matter of educating the doctors, it's a matter of making them aware that that patient is seeing another doctor. You can't do that unless you have a monitoring system in place. That will be the single biggest thing that can help drug diversion, as far as I'm concerned. Being in a pharmacy on a daily basis, that gets put into place, that will help drug diversion more than anything else that I've ever seen.
And to follow up on that with the monitoring program, because I think it's a great program. Take it from a sneaky recovering.
So I don't mean anything by it.
No. It's well earned. Trust me. What kind of cooperation is there going to be in interstate monitoring programs? Because let me tell you something. From being in southwestern Pennsylvania, if you're watching me here, I'm driving across the border. I'm going to Ohio.
Well, they also, Ohio, West Virginia have them, but just so you know, the federal government's working on, and actually, I think the Senate bill that Senator Pat Vance put in has provisions that are directing us to work across with the other departments, but also the federal government's working on it, trying to get all of those monitoring programs speaking to each other, because absolutely, you think about how much of our population, look at Philadelphia, look along here, along the west, like a huge portion of Pennsylvania's population is 40 minutes from another state, and they will cross over. Now, you're only going to be able to get two. I mean, those systems need to speak to each other. That's the bottom line, and that's going to be something that I think is provided for in the legislation.
And I think by doing that, you're going to be able to still treat the patient who needs honest treatment without tying a doctor's hand and saying, "Oh, now you have to watch this, and this." Now they're going to be able to see it. And I think that's a huge thing.
One of the great things about both the House bill that's got sent over to the Senate and the Senate bill that's starting to move is they also allow us to, the Senate bill has a Department of Health, which is probably the right place, but it puts us at the table, so we make sure we can work with the doctors about, once you identify the individual with a drug-seeking behavior, what are you going to do? Are you just going to say, get out? I mean, they could do that, but ultimately, I don't think that's going to, I think what we're going to do is we want to be teaching our doctors how to be as effective as possible in intervening and saying, look, you've got a problem. If you want to walk out of here, I can't stop you, but you've got a problem. And you're not going to be able to get what you're looking here. And you've got to basically do the kind of intervention that can be as effective as possible to get them into specialty care.
And I think this is huge. Really
it's huge, and I think there's some, legislators are here. I believe that I'm hearing really encouraging things about that legislation moving, so I feel pretty encouraged. There was a fight, I know, between law enforcement and the medical community about when I say our, I mean law enforcement's ability to get after the doctors that are really engaging at criminal levels. We need to be able to law enforcement needs to be able to get at the people that are really not practicing medicine. They're just making lots of money, the pill mills. And so there's a little bit of there's been a tug of war, but that issue on the Senate bill has been resolved between the Medical Society and the District Attorneys Association. So I think, there are still going to be people that are, by the way, there's one of the things you're going to hear from the ACLU, and it's just not true, is that this is going to be big government looking in on, what you're getting in your prescription medicines. That is a falsity. None of the legislation has it. This allows doctors to get information about somebody that's coming in, going bouncing from doctor to doctor. This is going to save thousands of lives, and there's no big government that's going to be knowing when you go get a painkiller or this. That's just not true.
Well, they're already reading our emails, so I really don't care. So that's okay.
Okay, we're going to move on to the next question, and this is for Secretary Tennis. What can a community do to prevent or reduce overdoses?
I'm going to start with another advertisement for your excellent SCA, Janet Kyle. I think the first thing I would do if I was wanted to organize my community is I would give a call. You have a really, really strong Drug and Alcohol Commission and executive director here who can help guide you. There are a number of models. The two models I'm most familiar with that are outstanding, and you can look these up, are Communities That Care. This is a proven model for really doing effective work at organizing your community. There's drug-free communities. Those are strong. That's another strong model as well. So I would strongly recommend those. In terms of reducing overdoses, that's like a big priority for us. We actually started an overdose rapid response task force to get law enforcement, ambulance services, other medical providers, treatment providers, to all those silos to speak to each other in corners, to speak to each other in real time about drug trends, so that if for example, fentanyl is popping up in your communities, we want to make sure that your police chiefs and your district attorney knows they'll send somebody in undercover and start making buys to get that stuff off the street. We also want to make sure your ambulance drivers know how to deal with whatever is the drug du jour that's popping up that's causing overdoses in your community, so that we can get them that immediate medical care that they need. I think another thing I would do, I just want to say a couple of things. I know you don't have me on the docket for naloxone, but there is legislation moving through to allow third-party prescribing for naloxone. I want to talk about what happened in Quincy, Massachusetts, and some of you may have seen this on TV. But the first Massachusetts legislature passed a law saying that police could have it. The police were reluctant in Quincy, Massachusetts. A city of 100,000, bad heroin problem. They were like, is this really our thing? They love it now. In the first 3 years of this pilot, they reversed 170 overdoses. The police did. 170 overdoses. Not only that, but from a policing perspective, their community police relations are probably better than anywhere in the nation. They get all kinds of information they need. I'm personally a big believer in law enforcement, so one of the things I would want any community to do is be militant about working with your local law enforcement, so that if you know somebody's dealing, if there's some kind of trafficking going on, give your police a call. This is life or death. And
When you talk about naloxone, you're talking about Narcan.
What's it?
Narcan.
Narcan is the brand name. They have several kinds now. They just came out with one of those injector auto pen things. They're a little more expensive. In Quincy, Mass, they use the nasal sprays. Unbelievable. And you can have a dramatic impact right there. So even if you have somebody in your family, your doctor technically can't prescribe to you for a family member, but if you can get your family member to get that prescribed, I think doctors should be, if they're prescribing some of the heavier duty opioids, should be co-prescribing naloxone. Probably the nasal spray would be best, since most people don't want to use a needle, or the little injector pen, the EpiPen. That could be good as well. But that is a surefire way, no side effects to naloxone, except for you are going through very, very rapid withdrawal, so sometimes people get agitated. The accounts of a violent reaction are overblown. I've looked at the research. It's about 4% of the cases people become pretty agitated and maybe a little bit like this. Our police officers know how to handle it, and I know our ambulance drivers do too, and they're already using it. So that's another thing I would try to, for the overdose issue specifically, I would look at. One of the things, before I wrap up, that we did with our overdose rapid response task force is we sent out a policy directive to all of our SCAs, the county drug and alcohol directors, and said, work with your emergency departments to work on a warm handoff, so that if somebody comes in and survives an overdose, we want to do the best we can in those emergency rooms to get them to treatment. And don't just give them a phone number and say, be on your way, here, call this or whatever, but try to do as robust an intervention as possible, because they'll overdose again. And many people who would die of a fatal overdose had survived prior overdoses. So that's a good opportunity to intervene. It's a crisis moment in the individual's life, which tends to be a good opportunity to intervene. We want to make sure we do that.
Okay, thank you very much. We're going to move on to the next question. This is for our Fayette County District Attorney, Jack Hennings. What percentage of crimes would you say committed in Fayette County are drug-related?
I would say if you include alcohol in addition to drugs, probably 80% of the crimes that we prosecute in Fayette County are directly related to drugs and alcohol. I wrote a quick list, and they start with homicide, and they go down through robbery, burglary, theft. We're seeing a vast increase in retail thefts. And in fact, what they're doing is going in, stealing the items, going back, converting it into cash, going and buying drugs with it, whether it's heroin, whether it's pills, crack cocaine. That is leading the way, as a matter of fact, in crimes in Fayette County. Unfortunately, what we also see, and this is the sad part, is that we see families that are the victims of the crimes being committed by their own relatives, by their sons, by their daughters. Those are the crimes that go to the heart of the family. I think some of our earlier statements where some of those are borne by the family in secrecy for a long time. They're ashamed, they don't want to go to the police, they don't want to tell on their relatives, they don't want to see jail for them. But unfortunately, time after time, after that addict, as it turns out to be, has committed those crimes over and over again, unfortunately they have to resort only to go to the police, and that results in the prosecution of those individuals. If you look at possession, the normal things that you think about, possession, delivery of drugs, trying to get drugs from pharmacies like Walt, those make up 10-20% of the crimes. If you look at forgeries, if you look at access device fraud, which is basically a fancy word for stealing somebody's credit card, and a lot of times it's the grandmother's credit card that's being used to go down and get money, to take money out, to take food out, to take merchandise out, again, to get money to buy drugs. If you look at the DUIs, unfortunately, they're both drug-related as well as alcohol-related DUIs. I think if you look at the breakdown between drugs and alcohol, it's probably now about 20 or 30% are drug-related, and the rest of that is alcohol-related. You look at homicide by vehicles, unfortunately, innocent victims killed by people driving a vehicle while they're high, either on drugs or alcohol. Those are, unfortunately, the vast areas that we prosecute. I have on my desk right now, unfortunately, about 8 burglaries committed by the same individual. He's 19 years old. And obviously, the reason that he committed those burglaries is very simple. He was high at the time, but he also wanted to keep being high. He wanted the heroin fix that he needed. He was up to, as I understand, a couple $100s a day. He had to steal guns, money, whatever, from individuals in this community. And unfortunately, that is repeated over and over and over again. And unfortunately, what do you do with a 19-year-old at that age that has committed those burglaries? He's going to go to a state correctional institution for a long period of time. And do I think that that's the best way to go about prosecuting someone like that? Unfortunately, it is, but is that the best for that person? No. And if we could develop through everything that has been discussed here today a way of getting to that addict before he becomes a criminal, that would save the taxpayers of Fayette County, the taxpayers of Pennsylvania, millions of dollars, and would save, if we were successful, the lives of those individuals before they went down the path that they had chosen to go. We have some treatment options in Fayette County. We have a day treatment center that's been established. We're trying to expand those operations, but unfortunately our options are limited. And I think that one of the saddest things that I do as the district attorney is when somebody's on probation or parole and they come in and they've actually been given a break to go on probation, or they've been given a release from jail to go out and hopefully live a life free of crime. And 1 month, 2 months, 3 months down the road, they come before the judge because they've tested positive for a variety of drugs, alcohol, and pills, heroin, crack cocaine, you name it. And what can the judge do? He has very little options at this point because the option is to send him back to jail. And unfortunately, sending him back to jail is only postponing the inevitable because once he gets out or she gets out in 6 months or 8 months, we're back to the same situation all over again. And they're still addicted. They're still going to go out and commit those crimes. We haven't at all interrupted that cycle. And my frustration, certainly from a district attorney standpoint, is not having the funding, not having the ability to send people for long-term drug and alcohol treatment. In fact, at this point, we've talked a little bit about treatment options, but right now, if I'm not mistaken, most insurance policies pays for about a 10-day drug withdrawal situation. I'm sorry, I think a guy or a gal addicted to heroin or pills is not going to get healthy with 10 days. And our legislators are here, and I know that there's funding issues all over the Commonwealth, but it really doesn't make much sense to me to pay whatever we're paying per day in the Fayette County Jail, the State Correctional Institution, when we could pay less if we had drug and alcohol facilities that would treat those individuals before they became residents of our institution. So from my standpoint, from the district attorney's standpoint, we have to prosecute who we need to prosecute, but I wish there were better ways to do it.
Just want to respond too about I appreciate everything you said and agree. 10 days is a ridiculous amount of time for someone. It's probably enough to kill them because you're going to relapse and you're at risk of overdosing because your tolerance is down because you've been off for a while. The act, just so you know what your rights are. If you have private health insurance, in most instances, you're covered under what's called an Act 106 benefit. That means you're entitled to a minimum of 30 days residential and 30 outpatient units, plus what are called 30 more flex units, which could be either another 30 outpatient units or 15 more residential. So it could be as much as 45 days residential. Still probably not enough for somebody with full-blown heroin addiction, but if you are dealing with the disease early on, it can be enough if you're caught soon enough. I mean, if you catch it soon enough. If you are Medicaid eligible, then you're entitled to, you are meant to get whatever you need. Now that's been an ongoing battle. I mean, we're trying to make sure that our behavioral health managed care organizations are really covering the level of treatment that you need. And that's a wrestling match, and that's something, one of the things my job to do is to meet with them, and I actually am meeting with one of their CEOs soon to try to explain that aside from the fact that you're wasting your money if you undertreat, like people, you're really, really endangering individuals by undertreating. You need to fund the level of treatment that's called for under an individualized clinical assessment, and then we have something in Pennsylvania, I think it's the best placement criteria in the nation, Pennsylvania Client Placement Criteria. We just came out with a new edition of it. We just approved it about a week ago, and we've been working on it for 2 or 3 years. Dr. Pringle from the University of Pittsburgh has been overseeing that for us. It's a clinical decision, just like if you come in with heart disease, you might be able to get better on a little exercise if we catch early. You might need open heart surgery if you're near death. So it really depends. It's an individualized clinical assessment, And I think we have to be prepared, and I come as a lawyer, so I think about it from a legal perspective. We need to be prepared to really demand that people get the level of treatment they need. And now there's a federal law called the Mental Health Parity and Addiction Equity Act, and that says we treat addiction like we treat any other disease. It doesn't mean if you get open heart surgery for heart disease that we're going to give you open heart surgery for addiction. It doesn't mean you're matching with what are called cognates. It means it's a clinical decision. You get what you need clinically. Ultimately, it's an issue that will be decided in the courts by the judges, probably by, just like the Act 106 benefit was decided. So your rights to treatment are very, very strong in this state. It's why we are able to do better than other states do. And we really need to be tough about it when you're seeking treatment for yourself or a loved one.
Okay, thank you very much. Next question is for Attorney Jack Purcell. What is the penalty of being in possession of a controlled substance or illicit drug?
Thank you, Mark. I am the solicitor for the Drug and Alcohol Commission. I've been in that position for more than 20 years. Very proud of the work that organization does. Tonight I think I'm sitting in here as the defense attorney to talk about representing individuals who are facing legal consequences for possessing drugs, especially prescription medications. And the short answer to what's the penalty is it's too much for you to take. So don't get caught with the possession of the prescription medications in a legal fashion. But short answer, Vicodin, oxycodone, two of the most commonly illegally possessed prescription medications. First offense, 1 year in jail, up to a $5,000 fine. Second offense, 2 years in jail. Third offense, 3 years in prison. So the legislature has seen fit to increase the penalties for multiple offenders. But that's just the beginning, the criminal, and maybe even the part that's less important. There's collateral consequences, other things that will happen. You'll lose your job. Employers have no problem legally firing someone who's possessing prescription medication illegally. If you're on or seeking benefits, such as workers' compensation benefits, you're very likely to lose those benefits if you're illegally possessing prescription medication. If you're in school, you're subject to being expelled from school, whether it's college or public high school. If you have a license, such as to practice law, medicine, pharmacy, many other things that you need licenses for, nursing, you're in danger of losing your license. Essentially, committing such a criminal act can really affect your life from then on. Employers certainly look down greatly on applicants that have a conviction for the possession of illegal controlled substances. And that's what they look at it. They look at it as this, it's just as serious to someone who's deciding, are they going to hire this person or that person for a job? They're not going to care whether it was marijuana or cocaine or whether it was illegally possessed Vicodin or oxycodone. We've talked a lot. I think maybe we put a little bit too much blame on the doctors for some of this problem. I think, and District Attorney Hennick's touched on this, I believe, and the Secretary too. We're the lawyers here on the panel. I think we deserve a chunk of the blame too. And the reason I say that is we have never really come to grips with the essence of the problem of addiction. Legally, we've looked at it with more of a sledgehammer. We're just going to pound it and pound the addicts and think that's going to work. And I was very encouraged to hear Secretary Tennis in his opening remarks basically say that's not worked and that's not the policy that the Commonwealth is going to follow now, because that's the reality. And that's been the reality of the literature, the medical literature. Clearly, that doesn't work. What does work is a more united approach with some punitive measures, but with a more emphasis on treatment. And when those two things come together, and they have come together in many places in the country through the use of drug treatment courts, which unfortunately have been slower to develop here in Pennsylvania, and we're just barely tiptoeing into the water here in Fayette County, and I think that's a tragedy, and that's something that we in the legal profession share some blame for. Now there are funding issues, and it's hard work, and it does take, the law changes very slowly. We change so slowly in the legal system, and that's a problem when you have when the problem that you're dealing with is always mutating, changing, growing, going here and there. But drug courts work. They've worked in many other places in the country where their drug problems are just as bad or worse than ours, and we need a commitment, I believe, from our entire legal system, from law enforcement, who does probably the best job, all the way through our court system. We need to find the money. We need to have an aggressive, modern, effective drug court system that will give District Attorney Hennicks, working with defense attorneys, better options, more options to help solve the problem in ways that will work, that the literature, the science behind this, there is science behind this, and the doctor will be talking more about that, that will work with the with the court system being behind it and having that ability to push people that need the push. And I think Bill will talk, because I've heard Bill talk before, and he mentions how the court system was the way that sort of pushed him to finally turn the corner. That will work, but we need the commitment from the system, and that includes the system that District Attorney Hennicks and I are part of, to work together to finally make a dent and really do something different. When you just can't keep doing the same thing and hope it's going to change, because it's not.
I'd love to see a 16% recidivism.
Yes.
I think that would be miraculous.
It's interesting
we would
because
have that, because we're probably at 60 to 80%.
We have our jail, which has a sign when you walk out. I've been going in and out of that jail. I don't go in much anymore, but when I was a younger lawyer, there's a sign they put, "I will never come here again."
I saw that sign.
And you did see that. Did you go back in? I mean, it just doesn't, people don't, it doesn't work. Just the punishment itself does not solve the problem with addicted folks that are committing criminal acts.
And just let me say, when Jack was reading out the maximums for possession charges, obviously we don't sentence to the max unless they really are repeat offenders, that they continually get picked up with possession charges. In fact, I've actually continued what Nancy Vernon did when she was a district attorney. If we have a heroin, we have a Schedule II drug, is our standard for a first-time offender is 1 to 12 months intermediate punishment, meaning that if they go to a rehab, they get credit for that. Or they stay out, they may have to pay for a bracelet for that 1 month, but we're hoping to encourage them not to go to jail initially, because we don't have room for them in jail. Plus, jail's expensive, and jail's not going to be the appropriate place, although I've heard Bill say that sometimes jail was the place where he learned. And unfortunately, jail is a last resort in that sense, but it's a very expensive last resort, and there should be other avenues to pursue before that. So we try to encourage, in the sense of a Schedule II, in the 3 or 4 drugs, a lot of times we do probation. We're now talking about day treatment center. So we're trying to encourage that kind of entry into the system, that we're not going to put them in jail right away. Unfortunately, those are the ones I talked about that keep coming back. And that 1 to 12 month sentence sometimes turns into
12 months, and then we spend all that money on that rather than the money going to 6 months of treatment, 4 to 6 months of inpatient treatment, which is really what the research shows that the hardcore addict needs. We talk about, the Secretary talked about 15, maybe 45 days. Even that probably is not adequate for the hardcore addict.
Absolutely. Actually, optimally for someone with a full-blown opioid or heroin addiction, I would think about 6 months, starting with 6 months residential, stepping down into a recovery house with intensive outpatient, and continuing to step down.
And I don't have the patience for that.
Yeah, and I've heard the analogy.
Well, that's really
nobody right now.
Clinically, that is optimal. That's where you're going to get the best.
That's where you get and I heard some, and I don't know if it was Dr. Woolhandler, some doctor, or somebody told me this, it's like when you only give people 10 days or whatever, it's like giving them 2 days of antibiotics. It just makes the problem worse. It really does not even come close to a solution.
The other thing that people have to keep in mind is nobody wakes up one day and says, "I want to be an addict." And, I mean, it's I mean, let's be honest, okay? I mean, everybody is anybody who's an addict is done by accident. Nobody does it on purpose. So the problem is, you know, we have to have things in place to help people. Let's be honest. I mean, we need the money in there. We need all of us. We need to
You have
support-
time afterwards to speak.
We need to support people who need help, and whatever issue it may be. And this is a very big issue. So we need to have these policies in place, and we need to have these programs in place. It's huge, it's big, and we have to find ways to do it. And we have to, you know, ask for the help. I mean, it's there. Yeah, we need the money.
We need the money and the commitment.
Absolutely. But we have to get that help.
Okay, we're gonna move on to the next question. This is for Steve Contaxis. What is the Drug Task Force?
Yes, thank you to Fayette County Drug and Alcohol for inviting us to be here tonight. And thank you to the audience for being here and being involved in this important subject. The Fayette County Drug Task Force is a law enforcement agency under the District Attorney's Office. My boss is sitting right here next to me, Jack Hennigs. And essentially, our main mission is to investigate and combat illegal drug trafficking in Fayette County. Well, how do we do this? One of the ways that we do this is that, of course, we depend on the community. And we depend on the community to give us information, to tell us about things that you see, things that you hear, and we depend on the community as any law enforcement agency. We also leverage other law enforcement agencies, such as the Pennsylvania State Police, FBI, DEA. We work hand in hand. We try to bring other resources into Fayette County. And I want to just say that we are funded by the Pennsylvania Attorney General's Office, and we're also funded by our Fayette County Commissioners, who, as of 2013, saw the need to step up and to provide additional funding for the Fayette County Drug Task Force. I do want to give you a couple of telephone numbers that, and just tell you a little bit about how can you get in contact with us. Well, first of all, if you have information related to drug trafficking and you want to give us a call, you can call and you can choose to call anonymously if you want to. The number is 724-415-3100. Now, one of the supervisors may answer the phone. You don't have to give your name. If you want to give your name, that's fine. You may get a recorded message. You can leave a message. If you want to call back, tell us you want to call back, and we will call you back. Give us your phone number. Because remember, a lot of times, you know, we get anonymous information, and we may have more questions. Well, if we don't know who called, and you don't want to call back, then we can't call you back. But if you do, the more information that we can get from you, the better it is for us to be able to work a case and be able to investigate. The other thing you can do, if you want to send us a fax, you can do so, and that number is 724-415, and that's 3101. So if you want to go down to your local COGOs and send a fax to us and have it be anonymous, that's fine. Or if you want to send us an email, you could do so at drugtips@zoominternet.net. drugtips@zoominternet.net. So if you feel like you want to send an email, that would be fine also. Our agency consists of about 52 county detectives, and the county detectives are all members of municipal police departments within Fayette County. So we get right down to the street level. These folks know what's going on in their communities. We also have a volunteer group from the Fayette County Emergency Medical Service, and these people volunteer as what we call tactical medics. And these are people that go along with us and on raids, for example, and they're the ones who are there to help keep us safe, provide medical care. We always, I never turn down offers to help. And You know, we've had people in the community that offer, how can we help you? And let me just say that we never turn down offers to help us. Thank you.
Okay.
And let me just say, and I didn't want to steal some of Steve's thunder because I know he's going to speak to this, but we have, I believe at this point, for the last year, we had about 150 plus cases that we have been following through the Drug Task Force. And as Steve indicated, these are retail operations. These are down to the street level, the house level, the neighborhood level, because some of the concerns, obviously, that I've expressed about treating addicts is that I have no compunction about putting drug dealers in jail. And we do that over and over again in Fayette County, and we do it largely as a result of what the Fayette County Drug Task Force does. And what they do is not simple, it's not easy. It's making arrangements with individuals to buy drugs, and it's a dangerous business, and it is one that has to be done with a great deal of discipline and perseverance and courage. And I certainly applaud the local police officers that do that. And without them doing the things that they do, this community would be much less safe. And as Steve indicated, we are funded by the Attorney General's office, by the county commissioners, and in fact, one of the other things we do is we do get forfeitures on cars and other things that we confiscate that are drug related. So that's an additional source of revenue as well. But it is one of those things that you probably don't see all the time in the newspaper. We don't publicize. I got a call the other day from the Herald-Standard about an operation we were doing, and we are not always prone to advertising that because one thing may lead to another, may lead to the higher source and the higher source. And that's sometimes where we don't see things in the paper about drug bust and things like that, but they're going on, and they're going on in an effective way, in a way that we're going to keep doing in Fayette County.
By the way, in terms of, Jack mentioned the volume of our caseload, and from the time that I started with the agency, which was about 2006, our caseload has tripled. And this year, I can tell you that it's growing. We just completed the first quarter, and I think I'm up to about 60 cases already in just the first quarter alone. So, you know, just the resources for us is a very difficult thing because we need resources to be able to keep up with the cases.
Steve, does a 911 call bounce over to you? Somebody wants to gonna get to you that way?
Well, generally the 911 calls, if it's an emergency call, it'll bounce to the police department. But, you know, information could come that way. If it's a non-emergency, it would be better to call the numbers that I gave you rather than tying up a 911 system.
Okay, thank you very much. We're going to move on to the next question. We're back to Elaine. What is drug and alcohol treatment, and does treatment really work?
I never thought I'd get that question. Does treatment really work? All right. What is treatment? It is the port in the storm for people who are addicts. This is where they have somebody to talk to and open up to, where they don't have to feel ashamed, where they can talk to educated people in the addiction field, where we can determine what level of care, and you heard something about the level of care, inpatient, halfway house, outpatient, those different levels of care. But we do so much more because you forget an addict is a person. And that person has a lot of areas in their life that they are struggling with. So somebody comes to us, they may not have insurance. And by the grace of God, we do get some monies in order to send them places. They come to us with mental health conditions that have never been addressed before. We help to direct them where they can get mental health counseling. So many of them have never had good medical care. We help them hook up with the Department of Public Welfare to see if we can get them some medical coverage. So many of them have never had any doctor care. And because we have a wonderful doctor who is willing to listen to people and help them in all aspects of their life, for the first time maybe in years, they get help. They get medical help. So what does treatment do? We pick up the person and we hold them. And we help them develop skills and coping mechanisms. Now, does it work all the time? That's a loaded question. Because if we know that addiction is a chronic relapsing disorder, then we know that sometimes it takes people a while before they really get it. What we hope is that they don't die along the way. That's what we hope. Treatment oftentimes has been looked as the miracle cure. Well, and we get this from a lot of individuals. They send their family members to treatment and you never see them. You never see the rest of the family members. They somehow believe that you can send your loved one to treatment, we fix them or spread fairy dust on them or whatever, and they come out on the other end being okay, being ready to just give up drugs. But you have to know that addiction is not just about using drugs. We talk a lot here about the legal aspects, the criminal aspects, the costs, all this. But let's think about that addict. Let's think about that addict or that alcoholic just for a moment. There were a lot of things that have gone wrong in his or her life. And sometimes drugs are the one solution that they find that gives them some respite. Is it a good solution? No, it isn't a good solution. But does it give them a little bit of respite for a while? Yes. So what do we do as treatment professionals? We try to help them understand why they do things that they don't want to do. I had a girl in my office today, heroin addiction. Well, because Dr. Bob has helped her with that, but unfortunately she hasn't really worked with the rest of her addiction. She's now using cocaine. And so she sits in my office with track marks all over her arms, crying on what a terrible person she is. That's what we work with every day, to let people know that they're good human beings who happen to get this addiction, which causes them to have bad behaviors. And I don't know many other forums, other than 12-step meetings maybe, in which somebody can walk in and they aren't judged as being a bad person. And I can honestly say, within our agency, we look at people as people, and we do everything we can to help support them emotionally, spiritually, mentally, and also physically. And that's all we do. Thank you.
Elaine, just let me, one of our advantages that I had is we had a caravan that went around last year to various schools. And one of the stories that I was struck with, and I'll let Elaine relate this because I've certainly used it, and I told her I was going to use it and attribute it to her. But it was involving a person that was on his way to try to recover, but telling Elaine how hard it was because everybody thought he was going to be a failure. And go ahead, you can tell it better.
No, you tell me. I want to hear it.
She related that this gentleman came in after he'd been in treatment and came to her and he said, you know, everybody expects me to fail. Everybody, my family, my friends, law enforcement, the district attorney probably, everybody thinks that I am going to be an addict for the rest of my life because I've repeatedly failed to recover, I've relapsed, I've gone about doing things that I really didn't want to do, ended up in law enforcement. And to him, one of the hardest things to him was not to live up to those expectations. And I was struck by that, and I'm still struck by that because I think that shows some of the things we've talked about way back when was hope. And I think that certainly has to be the message, obviously tempered by the realities of addiction and the situation that Steve and I and everybody else here has to do with it. But still, we hold out that hope, and I was struck by that because, and I think maybe Bill and Brendan are going to speak to that as well. I don't want to steal their thunder either, but I certainly was struck by that. I think people should understand that as well.
Okay, thank you very much. We do have one more question before we get to Bill and Brendan. It's for Dr. Woolhammer. What is medication-assisted treatment?
Again, that's a very large topic, a very large question, so I'm going to try to simplify it and be brief. But most of the treatment for addiction is centered around behavioral modifications, 12-step programs. We're big believers in that at Fayette County Drug and Alcohol, and that's been our main thrust. But over the years now that we're starting to understand the brain chemistry better, we're finding parts below the cognitive part of the brain, deep into the brain centers in the hippocampus and the ventral tegmental area, where these cravings seem to be developing and where these triggers are. So we are now trying to work with medications to assist treatment, not to substitute for treatment, but assist treatment, make it more available for people, especially people that are motivated. We have so many people come in and are motivated toward treatment, but the obsessions just are so strong that they're unable to get into treatment, or they go to multiple rehabs. And what we're working with, I want to talk about some of the treatments, but the one treatment we work with is, we work with long-acting naltrexone or Vivitrol as a way to reduce cravings, sometimes eliminates cravings, and also prevents people from getting high. It's non-addictive, and so it's one of the tools we have. There's also, I don't want to get into all the medical assisted treatments, but there's also methadone and Suboxone. We sort of aren't big believers of those. They're like, this is my opinion here, they're more like drug substitutions, but they are, I guess, medically assisted treatments that people can have as they get 12-step treatments. But I think this is the part that I'm sort of most interested in. I know the 12 steps work, but I always, after all these years, felt that it worked, but not enough or not as often as it could work. And I think as we start to take the brain chemistry apart, we're going to have more and more medicines available to combine with drug and alcohol traditional treatment.
Okay, thank you very much. Okay, now we're going to have Bill and Brandon relate their stories. So we'll start with Bill. Can you share with us your story about your journey to recovery?
Well, I mean, the first thing I want to say, I guess, is that, you know, I want to recognize, you know, the importance of something like this. This is a problem that I've struggled with my whole life. I've been sober for 4 years, 10 months, continuously, from all mood and mind altering chemicals pushed or prescribed. It's very important that I say that. And, you know, I just want to say, as I was sitting here listening to the, you know, to the conversation, and how much I've learned, you know, myself, because of all the, we've done this, about half a dozen times now all over the county, which has, you know, prompted me to really look at the issue and to read more and to get more into the research, you know, behind some of the treatment methods and behind some of the statistics and just how big the problem is, and it's been very eye-opening. I mean, I had a sense of it from my own experience in my lifetime. I was an active drug addict for more than 20 years. Intravenous heroin addict, crack cocaine, alcohol, been to jail many times. Fayette County was one of them. I've been to rehab 8 times. I've been in 3 different halfway houses. And that was all before I got clean. And I've been on the methadone program twice. I've been on the Suboxone program once, again, before I got clean. And so I had a considerable frame of reference for what it was like to live the problem and see what it was like from the inside. Now, having been clean for almost 5 years, you know, and being a part of this, and I want to thank Erica for kind of pushing me to do it. It's really given me a perspective on the problem on a larger scale. And I just want to say, first, my heart goes out to the parents. I feel bad for parents these days because and as the father of a drug addict, my mother was an alcoholic. I'm a recovering drug addict. My son thankfully came into recovery this last year. He was using heroin. Just celebrated a year clean. So I know it from both ends and from the middle. My heart goes out to parents and to the police and to especially to the police and to the parents because they see it every single day and they deal with it every day, and it's a huge problem. And as I was sitting here thinking about all that, and I was thinking about my son, and I was thinking about my mom and my dad and all the things that I put them through over the years. I just, the thought that went through my mind was, I'm so happy that I'm clean. I'm so overjoyed. I'm overjoyed to be clean, to have the life that I have, to have had the opportunity that I've had through the help of a lot of people, to have a second chance at life. I'm a student here at Penn State. My life is unbelievable compared to what it was like 5 years ago. I was homeless. I was living in the Uniontown City Mission. I was 36 years old. I didn't have a job. I had charges pending. I had warrants out for my arrest in several counties. I couldn't keep a job. I had no car and no driver's license. I had not a penny in the bank, and there wasn't a single person on the face of this planet that I hadn't burned. And there was nobody left that really wanted to hear anything that I had to say because every word that came out of my mouth was a lie. Every time I told my family that I was sorry, it was a lie because I ended up doing it again. Every time I told my family I wouldn't do it again, it ended up being a lie. And all that ended, all those lies and all the stealing and lying and all the things that we've talked about ended for me June 3rd, 2009. That was the day I got clean. I got out of an inpatient and I was there for a short period of time, 13 days total. And I agree with you. 100% of the 8 rehabs I went to, the last one, the 8th one, served about as much purpose as the prior 7. And I made some friends. I will say that. I did meet some people in rehab that we hooked up after we got out. So, and I made the trip to Uniontown, and I ended up at a meeting. That's where I ended up. That's where I knew to go, and I called a guy, and he told me, he said, "Have you had enough?" Because as enthusiastic and optimistic as some of what has been said here today, especially about the treatment end of it, has been, I have to point out that there's a certain amount of the stigma of being a drug addict that's earned. There are a lot of drug addicts that simply don't want to get clean, and that was me for a long time. When I finally saw, and like I said, I was 36, I'm 41 now. When I finally saw what the true price of drug addiction was, that was about 5 years before I really started trying to get clean for real. It was already too late. Things continued to get worse and worse, and then, like I said, when I was at death's door, basically, I found the ability to I think say my first honest prayer, which was, "Please, just let me stay clean," and that was it. And that was the beginning. It was really a total abandonment of any other objective in my life, outside of the singular thought of, I just have to stop getting high. I can't worry about my kids that I had lost custody of. I can't worry about the money that I don't have, or the job that I don't have, or the house that I don't have, or any of these other things, because none of that's going to matter if I can't stop getting high. If there's one thing that I want to say to the families that may be here that are struggling with family members, and I'm sure that they're here tonight, the only thing that I can say is pray. Don't lose hope, but don't help them. Don't help them. Say no. Tough love from the families is really the only thing you can do. You could push them in the direction of treatment. You can push them in the direction of going to get help from other people. But other than that, there's not a whole lot you can do. Every penny you give them, trust me, I'm telling you, it's going to go to drugs. Other than that, when I heard, the conversation about what addiction is, you can take the flip side of that in a lot of ways and talk about what recovery has been for me. Addiction was a coping mechanism, and the brain chemistry and all that nonsense, that's fine too. But I was 12, and I learned how to cope with my life and my insecurities and my problems. I learned how to cope with the guys that were taller than me, the guys that were faster than me, the guys that got the girls that I couldn't get, or whatever. I learned how to cope with the families that had parents that were still married and I didn't, by taking a chemical. Because I was 12, and it was there. And as time went on, that friend, that relationship that Elaine was talking about, betrayed me. And like I said, by the time I figured it out, it was too late. Becoming psychologically, physically, emotionally, completely dependent on a drug. It was the only way out. It was the only way out of how I was feeling. At least I thought that for a while. And in recovery, it has been the opposite. 10 days is clearly not enough time. When I had about 11 months clean, me and some friends of mine started a house here in Uniontown, and you talk about treatment options. There are places that exist. They're not that easy to find sometimes, and they're hard to fund. But it's been up and running for about 4 years now, and I can tell you very simply the way that my friends and I stay clean is that we stay away from people, places, and things. We don't go into bars. We don't go around people we used to get high with, anything like that. We pray. We try to develop a relationship with a higher power. It can be however you define it. God, for me. And we try to help other people. And for the last 4 years, the house has been up and running, and that's basically it. It was a slow process of building new behaviors that took the place of the old behaviors. Everybody lies. Raise your hand if you don't lie. Okay, good. But as a drug addict, I took lying to a whole nother level. It became a survival mechanism. Everybody steals from time to time. Somebody's stolen something in here. Even nuns steal pieces of candy sometimes. At least I'm going to say they do, for the sake of argument. But I took stealing to a whole nother level because it was a survival mechanism. In Maslow's hierarchy of needs, has everybody seen the pyramid? It starts off with like safety, security, food, shelter. It goes on up through the levels of belonging to something, and then higher calling, and it just builds to the top where you have a purpose in life and stuff. Drugs compete for everything on that list, and they take precedence over everything else on that list. So, and I'm saying this to try to give an idea of what it's like. And recovery, in many ways, is the opposite. To the extent that you were self-centered and selfish and self-seeking, you have to try to be less so. And it's a struggle. Less so in recovery. To the extent that you chased after the drugs, you have to be willing to chase after things of a spiritual nature, helping other people, trying to tell the truth. Like I said, I was a liar, and now I try my best to tell the truth. And that's what basically has been the journey, with a lot of help from other people. When I showed up at my first meeting, a guy grabbed me by the hand, and he said, "Come with me if you want to stay clean." Took me out of the mission, put me on his couch, fed me every day, stayed with me 24/7. I wasn't allowed out of his sight for the first 90 days, which is how we run it at the house. 100% supervision for the first 90 days, and based on the willingness of the person in that 90 days, we'll make a decision at that point as to whether or not they're able to assume more responsibility. We don't encourage, as a matter of fact, we strongly discourage new members of the house to carry money, to have a cell phone, to have access to a car, because every single one of those things equates to a bag of dope, or a pill, or a drink. You have to understand the currency of drug addiction. The currency of drug addiction is anything. Absolutely anything. I went to the drug dealer's house one time with 6 old CDs, a toaster, and free hats.
and got what I wanted. So you have to understand that kind of stuff. You have to understand what it is to be a drug addict in order to really help a drug addict. And that's what recovery has done for me. One thing I do want to, before I close, say is that I really strongly, I really hope that the treatment mindset that has been in place, and like I said, I've been through the ringer, I know what it's like, will begin to hopefully, now that the light is being shed on the problem of prescription drug prescribing and overprescribing, is going to move away from drugs like methadone and Suboxone, which do not help, and more towards the behavioral health side of things, more towards the operant conditioning. That's basically what addiction was. I was conditioned through. I was the rat in the box, hitting the lever. That's what I was. I was the rat in the box. Steal this, get a thing. Steal, whatever. And in recovery, it has been. It's a tough road at first, but it's been extremely rewarding. And I just want to emphasize that. I hope that it'll become more of a behavioral health issue and less of a medication-assisted issue as time goes on. Thank you.
Thank you. Okay, Brandon, can you share your story and maybe how yours was a little bit different from Bill's?
Surely. My name is Brendan Rennie, and I am a white Christian heterosexual male from a wealthy family with no major physical problems and really not many mental problems aside from depression and addiction. And having said that, if you were to look at my life on a piece of paper, you might think that, I won the lottery the day I was born and that nothing bad should ever happen to me. But I'm not sitting here right now because I got a PhD or because I'm a lawyer. I'm sitting here right now because in the last 11 years, I've been to 8 different rehabs and more AA and NA meetings than, there are stars in the night sky. And the reason why I mention that is because one of the questions that was asked earlier is, what does an addict look like? An addict can look like me. Despite all the many blessings that I was born into, I was just as much a heroin addict as, many other heroin addicts who also had perhaps many more reasons to justify being that way. One of the first things that struck me when I got into recovery and would go to meetings was I would hear people talk about their lives and what had happened to them. And they're just horrific stories. The scariest story you'll ever hear is in an AA or NA meeting. And I thought, wow, I don't have anything like that. That doesn't mean like my life's perfect, but in comparison, I don't have these stories. And eventually I realized that it doesn't really matter. Addiction is, an equal opportunity kind of ailment. It doesn't care about your background, your race, your religion, your gender, absolutely any of that. Anybody can become an addict. And the way I think of it, there are a lot of different kinds of addicts. For me personally, it's sort of like a birth defect where some people are maybe born without a leg. I was born without self-control. And whether drugs, alcohol, candy, sex, spending, anything that can take me out of myself, I can turn into a problem. The only thing that's not true of, I hear that some people get addicted to exercise, and I've not been able to do that. But there's still time. So, and I'm fortunate that I'm like that because I was as much of an alcoholic as I was an addict, and I do not have memories of the good times. Any good time, if I were to try and tell it to you right now, I'd be leaving out a big part of it that was like the bad time. So I don't have any kind of I don't miss it, or anything like that. And because of that, I still go to AA and NA meetings. I go to them regularly, and the program fits me to a T. Like, if you read the big book, you will be reading about me. But I also have known many people for whom, that's not true, and they can't say the same. Just very recently, I met a woman who was a binge user, which means that unlike me, where I used all day, every day, she can go for 4 or 5 days without getting high. But when she does get high, she breaks out in handcuffs, is a common phrase that they say at meetings. And is she an addict? I mean, I took her word for it, But for her, she really struggles with the idea of powerlessness. And I get that. For me, I can say I am powerless over alcohol and drugs, and that when I take a drink or I use a drug, it becomes extremely difficult to stop that behavior. But I've been in rehabs with people who never started drinking before 5 p.m. And you know what? You can still get physically addicted to alcohol. You can still get a DUI if you never drink before 5 p.m. You can get cirrhosis if you never drink before 5 p.m. But to some extent, unlike me, they didn't get drunk first thing in the morning. And that's really why I'm here, is because what worked for me was a combination of meetings, as well as intensive outpatient, and as well as various medications. I think that addiction is a very complex and multifaceted issue, and it can require a very complex and multifaceted treatment in order to have the best possibility for success. And it depends on everybody, As I said, there are many different kinds of addicts. A heroin addict and an alcoholic are both addicts, but they will probably have very different experiences. And their ways of getting clean and sober might not necessarily be the same, and there's nothing wrong with that. I'm a big fan of AA and NA, and I very frequently try and convince people who, for whatever reason, do not like AA or NA to try and go to meetings with me. And, the first thing that they mention is the whole spiritual aspect of it. And as Bill said, it's a higher power of one's understanding. It does not have to be God. But people get hung up on that. And for me, the value of AA and NA is that I think that people who are not addicts could really benefit from the 12 steps. I come from a family that's very proudly dysfunctional, and from the 12 steps, I've learned how to deal with that. I took my dad to an AA meeting for the first time. He's never been to one, and I brought up the topic was, family, dealing with family in recovery. And of course, because I brought that up, like 90% of what people talked about was their husbands and wives. And I looked at my dad, and he's sitting there, and I thought, wow, my dad really wishes that he was an alcoholic in AA, so he could go and hear about this more often. And what it has done for me is it has given me a way to hold myself responsible. Like, for me, it wasn't so much about finding God, but for realizing that I'm not God, and that I'm a part of a world that is not necessarily more important than me. And that means that I don't have carte blanche to engage in really negative, destructive tendencies because I feel like it. It has allowed me to recognize when there are situations that are out of my ability to control. One of the biggest things I've learned in my life is the ability to recognize when I just have to step back from something because there's nothing I can really do to change it. And because of that, I think that AA can really offer that. But I also am on Vivitrol, and I've been on Vivitrol for 9 months now. I have a little over 9 months clean and sober. And when I first got on Vivitrol, I was trying to go to meetings, and I wasn't hearing anything because my cravings were so bad that, I mean, it was like my ears basically didn't work. I was hearing all the information I needed, but I wasn't remembering any of it. I was so caught up in these constant cravings, and I really cannot describe it if you've never had it, and consider yourself lucky. It's definitely nothing to ever hope to experience. But for me, I went on the Vivitrol shot, and I really didn't want to get it because in the back of my mind I thought, like, you know, they're going to clip my wings. What am I, you know, what if I can't get high anymore? Like, a bunch of ridiculous stuff. I mean, my concern was, what if I still really want to get high? And as soon as I got the shot, I felt all of those cravings just kind of like dissipate. And this is not true of everybody, but this was true of me. It was like putting a hot frying pan in the sink and turning on the water. Like, my mind calmed. And the next AA meeting I went to after that, I was able to start the program and start listening to what I was hearing there. So when I think of like something like Vivitrol, which is naltrexone Revia, it's an injectable form of Revia, and when on it, it prevents getting high from any opiate for about 3 or 4 weeks. And when I think of like what role that played for me in my recovery, it's sort of like if there's a house fire, and you know the firemen are trying to put out the house fire. For me, Vivitrol was the axe that they were able to use to break the door down, to get the fire hose to the fire to extinguish it. And of course, you know, in saying that, Vivitrol alone was not gonna, you know, get me clean and sober. There are plenty of other drugs that I've gotten addicted to for which they're not blockers. But it gave me breathing room, and it gave me an opportunity to have 3 or 4 weeks, no matter what, when I was not going to be using my drug of choice. And it gave me the chance to make recovery work for me. I think that like very recently I was speaking to somebody. I was at this this event, sort of like this, that Congressman Murphy held at St. Vincent College, and while there, he introduced me to a woman who had just lost her son from a heroin overdose about 6 months prior, and in front of a room of there was like 150 people there. He had me look right at her, and he asked her, "Do you have anything you want to tell him?" And the look in her face, I saw exactly what happened. The first thought in her mind was, well, why you? You know, why are you here? Why was my son not here? And of course that look went away because, you know, that's not the kind of thought that people want to say out loud. But I've also actually been explicitly asked that, and the answer is, I don't know, you know. I know a lot of people who are not, you know, sitting here right now, and it's not because of anything that I did better or that they did worse. I honestly don't know. The reason why I am getting involved in this stuff is because I believe that a lot of good can be done, and rather easily and rather quickly. I find that Elaine mentioned the fact about the families, that there really aren't. There's Nar-Anon and Al-Anon for families, but there aren't that many meetings. And the thing is that, you know, whenever I went to rehab, I got to go to rehab, but my family didn't. And when I got out of rehab, I moved back in with them. It affects the whole family, and such an important part of recovery is addressing that. And I don't see that being done enough. And yeah, just in addition, you know, I've heard people criticize something like Vivitrol, and I'm not a doctor. I can't tell anybody what to do or what not to do. But ultimately, and this is the last thing I want to say, I originally got into recovery to get sober and to get clean, but now I am actually in recovery to find a better way of life. If somebody could tell me that I'm never going to drink or use drugs again, but I'm going to be so miserable that I'm going to jump off a bridge someday, when I do that, I'm going to be every bit as dead as I would have been if I had overdosed on heroin. for me, there's got to be more to it. There's got to be a change, a fundamental change in who I am and how I deal with the world. And like, for instance, I'm on antidepressants. Am I addicted to them? If I stop taking them right now, I'm going to have like 3 very bad days. But they don't make my life unmanageable. They make my life more manageable. They deal with one of my issues, and then I am more able to address the other ones. I mean, furthermore, I'm an asthmatic. Am I dependent on my inhaler? I mean, I guess. If I don't have it, I can't breathe. But, you know, the thing about it is that when we talk about addicts and addiction, there are people like cigarette smokers or addicts, but they don't go to rehab. And what I'm interested in is finding ways to figure out why people become addicts and how to prevent people from becoming addicts and address the root of the problem, which isn't a specific drug. They can find another drug. It's very complex, and I mean, I don't even know what it is, but that's why I'm sitting here, and that's all I've got. Thank you.
Thank you very much, Brandon. Okay, we're going to move into we're going to take questions from the audience now. The only thing I would say is that we do want you to come down speak into the microphone so that people can hear what you have to say. And also, try and keep your comments brief. We do want to give everybody who wants to speak a chance to speak. So,
I apologize. I believe we've got about a 3-hour drive out to Harrisburg, so we can take off.
Okay. Yes. Thank you very much, Secretary Tennis. He has to leave.
Yeah, thank you, Secretary. I've been here all night. I'm from the Office of Representative Mahoney, and we're very involved with these events, so thanks for coming down. Talk to Ron Young in your office and some of your other, Jeff Reed and the guys. But I just want to thank the panel. I was at Uniontown High School when we held the forum, and I think Brendan wasn't there at the time. Thank you for coming. And I think that, Mark, did you host it? Was you the moderator at Uniontown High School? Thanks, you did a wonderful job tonight. But my only comment, I'll say it real quick to the Secretary. Mr. Tennis, this will only take 30 seconds. We had talk about this methadone. I was just hoping, and since the legislators are here, and I know we have a good core of legislators here in our region right here, and Pam, I already congratulated her on the appointment to the suggestions to the policy committee. Very important, just as important as all the committees in Harrisburg, I believe, because of this epidemic. But I was just hoping that this funding stream in Harrisburg would go more to long-term, we already heard this, but long-term treatment instead of clinics. I mean, these clinics are popping up on every corner, methadone, and we can't get regulations on it from Harrisburg. They keep it on it for years. They keep these addicts. And the reasoning behind this, I get so passionate because this is my passion, people in recovery. We're watching these young people. It's in the grade schools now. I think we know that. We got to come out of denial. I'm not saying we're all in denial. I don't think the ones here tonight are in denial. But it's getting younger and younger. And they're putting that spike in their arm. And it's history, like the doc said. They hit the floor and they're dead. So I hope that the funding goes to long-term treatment, such as halfway houses and three-quarter houses. Because I think that's where the answer is. And thanks for the...
I agree. And just very briefly, Secretary Dennis, you have a long drive. I actually worked, this is from the CDC. These numbers are a little old. They're the earliest numbers I could find. This is from 2009. Methadone deaths have risen 7-fold in less than a decade. Number of drug poisoning deaths involving methadone, which is a synthetic opiate analgesic used to treat opioid dependency as well as pain, increased 7-fold from 800 deaths in 1999 to 5,500 in 2007. That's one of the reasons that I couldn't agree with you more, Neil, in that there's a gap in the mindset where things like that are categorized along with the same things that Dr. Woolhandler and Elaine and others in recovery are trying to do in intercall treatment.
Okay, let me respond real quickly. We have a methadone death and incident review team. We actually started when I first began.
Well, you know what?
And we started about 3 months later. The legislature actually passed a law to sort of spell out how we're going to operate. We finished our first year. We actually, I think on May 12th, our team meets. It's from all different sectors to look at what we can do to make it safer, more effective, also to work people, get people off if we possibly can. The other thing I want to say, here's the conundrum. I'm just going to lay it out for you. If I'm the single county authority, with the funding that I give them, that comes through ours and also comes from the Department of Public Welfare, if she gives people, I'm in agreement, by the way. I would love to see more people getting long-term residential who need it. That's just critical. That's my mission, is to get people clinical integrity. And that means if they need long-term residential, that's what they should get. I came in, actually one of the first things I did is I wrote a memo that was going to go out to all of the SCAs saying, you've got to follow the Pennsylvania client placement criteria. If they need long-term residential, you got to give it to them. I sent that out to prepare around, and I started talking to some folks, and they said, if you do that, if you make us do that, we're going to, the fiscal year starts July 1st. We're going to be out of money by Halloween. So that's our problem. That's our challenge. So then you're an SCA and you're thinking, well, do I run out of money and then just let everybody else die from Halloween until the next July 1st? Well, at least they can maybe keep them alive. So they're trying to figure out, they're in a very, very, Jana and we have a couple other SCAs in a very tough spot to try to figure out. My job is to make the case that you just made, which is we've got to step up and increase the resources. We need to demand that with our private health insurance, with our Medicaid health insurance, that people get the level of care they need. That's our battle. It's to restore, it's to get more resources so everybody who needs long-term residential, followed by intensive outpatient and case management, all the things we know that go into successful treatment, all that stuff we know, the research shows us this stuff works. We've got to get the resources to do it. So that's our battle. And it's not there. We're not there. We just aren't. We got to push for it. That's why you'll see me talking about getting people that we're putting into treatment at county, after 6 months in county jail, and saying to law enforcement folks and the judges and the county commissioners, let's get them out a couple weeks after they're in jail, and you give us those savings so we can get them the long-term residential they need. So we're just fighting. We're fighting the fight. We're engaging in it. Your point's well taken, and I wish the solution were easier. I really do, but it's a tough. It's our quest, and it's what we're working on, and we will work with you on it. Okay.
Thank you, Mr. Secretary.
I'm sure everyone is tired and wants to go home, and I wish that I could have had a chance to speak with Mr. Tennis. It's the first time I've met him, and I am so impressed. So very impressed. I was concerned when I heard he took the position because I heard he was on the law enforcement side, but he really is on the human side, and every one of the law enforcement people here tonight are on the human side of this. We've come a long way. Nobody wants to incarcerate, everyone wants to treat and have people get well. We all agree locking people up is not the answer. All they do is suffer horrifically, and they come out and they relapse and suffer horrifically again. I just wanted to mention that, Brendan, I was very impressed how open-minded you were. Vivitrol is working for you. I know a lot of people that wanted to come here tonight because Vivitrol is working for them. It's non-addictive. I just wanted to make sure everyone knows that. It is a non-addictive medication, and it's for relapse prevention. But I thought it was really cool how you are taking medication-assisted treatment, but you also are open-minded to the AA and NA part. That's awesome. So you're not closing your mind off to something. And I work in treatment, and sadly, I spend my evenings reading. and NIDA, Nora Volkoff, the director of National Institute of Drug Addiction, Harvard, they are all studying the biology of addiction now. And medication-assisted treatment is coming to the forefront. Even Hazleton, which is pretty wild, Hazleton is one of the first people out there treating addiction, is now using medication-assisted treatment. And Suboxone may be a drug that has a bad name, and that's because we don't have parameters on who uses it. Suboxone works if it's used correctly. Sadly, for whatever reason, anybody and their brother can write a prescription for it. So that has to change. But Suboxone will work if it's used in the right environment, but it's not. And it should be used in a taper position. You know, we don't want to get people addicted. It's very addictive, as Dr. Rulehandler says. It's very addictive, and we don't want to put young people on it. But we're seeing great things about Vivitrol. So what we need, and I wanted to ask Gary Tennis this, and I don't know who's here from the state, the senators, the representatives. We need to find a way to make Vivitrol available, because our biggest insurance provider, Highmark, will not cover it. So I'm seeing people on a non-addictive medication get well. I'm seeing it every day, and yet the biggest provider, insurance provider, won't pay for it. And again, I'm stressing, it's a non-addictive medication that blocks it. Brendan just said it allowed him to think, clear his mind, and use resources like AA. So if there's anybody here from Harrisburg that can help us with that, that's great. And I agree with everyone, long-term treatment, abstinence, that's where everybody's head is. We all agree on that. But if we have some sources that we can use, resources like this, I'm just asking whoever out there can help us get coverage for this. I'm seeing people, parents count pennies and quarters and dollars because they're afraid their child's gonna die. And they've heard about this medication and they can't get it covered. So that's just what I'm asking, if anybody has any resources to touch on that. Thank you.
And just for the cost, just say what the cost of Vivitrol is per shot.
The cost for Vivitrol is $642 a month. That's the cost of the medication. But I'm going to be really blunt on this one, because I'm a parent that buried a son. And my friend Barb here was going to speak. She buried a son. I also have another son he'll be 5 years in recovery on May 15th. My younger son used Suboxone. Elaine knows him. They're very close friends. He took Suboxone for 18 months. He slowly tapered off of it, slow taper. I'm sorry, but if my child was on a low dose of Suboxone but was alive, God, yeah, that's fine. When Dan used Suboxone, Vivitrol wasn't available. It wasn't approved. Do I think Vivitrol is a better choice? Yes, definitely. It's non-addictive. It's non-addictive. We don't want to get, and you're talking about young people using drugs, we don't want to get them addicted to Suboxone. No. But we need help getting this medication approved. But the bottom line is, if it's $642, you tell me what the cost of an ER visit is, the cost of an intensive care visit, the cost, I know I've been there a million times. Barb can speak for me. I've been in more ERs and intensive care units than I ever want to be in my life. So the cost of that medication, I'm sorry, it's a foolish question. Compare it to the cost of a life.
Yeah, I'm only asking it because I agree with you. It should be available, but the price right now is making it prohibitive.
Why does medical assistance,
I don't understand either.
CCBHO, VBH, they pay for the cost of the medication? Because it's cheaper. And we talked a lot about cost, and I'll tell you, I got a little bit cranky when I was hearing cost savings, because I'm talking about human lives. And whoever made the comment, I'm sorry if I'm being rude, parents have to get back to being parents. Whoever said that, I'm going to apologize to you now, because that was a really stupid comment. We've been parents. Barb and I have been parents. We never stopped being parents. So please, don't say that again. And I think you're not running for re-election, so it's not going to matter. But don't say that again. because we never stop being parents. From the time they started with their addiction to the time we buried them, we never stopped being parents. But back to your comment on the cost, you know, the prescription companies make money. We don't complain about a cost for a medication to cure cancer. Nobody complains about that. So let's stop complaining about the cost of it. We need to get the insurance company to cover the medication to save a life.
Just to make it clear, I wasn't complaining.
Okay.
I'm just saying it's outrageous that it's that amount and no one is under coverage that can get it. And I thought it was
Medical assistance is.
I thought it was $1,000.
Yeah, there are other health plans that do cover it.
I do believe
UPMC covers it. I believe.
UPMC commercial covers it.
Right.
UPMC commercial covers it.
And if you recall,
CCBHO, which is medical assistance, and VBH covers it. Because they're smart enough to know that they're going to save money from ER savings, intensive care savings, and I just don't understand where Highmark gets off with this holier-than-thou thing that they should take Rivia. Shame on Highmark, because I'm tired of having parents come in and they'll wipe out their life savings, and we've done it, and we'll continue to do it if we have to. But somebody in the state needs to make Highmark accountable for not paying for a non-addictive medication that is stopping cravings, and it's a blocker. And I see it every day because I work in treatment. And why do I work in treatment? Because I had a son die, and I have a son that's alive today. And Brendan's right. I was that person who thought, didn't happen to someone like me, didn't happen to families like me. Never will I say that again. Never.
I think that you need to call the state insurance commission.
We've been there, done that, done everything.
And they don't.
No. So, or an ASAM certified or an addiction doc. For some god crazy reason, you can write Suboxone on the side. That's ridiculous. And that's where people get angry about Suboxone, as they should. But if used correctly, it does work. Enough of that. I'm just asking for some help to get coverage for a non-addictive medication that works and saves lives. And I think Barb actually has a son using that medication. So if you want to attest to that. I know it was more than 5 minutes.
I do have my remaining son who is getting Vivitrol from Dr. Woolhandler, and he's had great success with that. I think I can tell that Bill's not real happy about the Vivitrol.
That's the Suboxone and the methadone that I have.
Okay.
Huge amounts of Suboxone and methadone are diverted every
Okay,
day for these.
because I know that I've told
drug addicts
other
on the street.
recovering addicts, because I go to schools to speak all the time with
And I
recovering
agree
addicts.
with you when you talk about the methods that are being used. I think that there is a place for Suboxone.
There is.
I think that it's in an inpatient, under close supervision by a medical team for the use of detox.
Well, I will debate you there, but we both agree if it's used properly.
We both agree that there is a place.
But that's okay.
But there's improvement. There's a lot of
Used
improvement.
properly, it works. But whoever allowed it to be used improperly, shame on them. I think we're in agreement of that.
Well, Reckitt Beckensor Pharmaceuticals, who has the patent,
That's okay.
made $3 billion in 2011.
But you know what? Honestly, Bill, probably 15% of their money came from Suboxone. So
No, that's Suboxone profits, $3 billion.
There's
That's one drug.
There's no point to pick on Reckitt. It's how it's used. So let's skip over that. Not pick on the drug manufacturer, because we can pick on a million. Let's start with Purdue Pharmaceutical if we want to start a debate. But let's skip that. But you and I are in agreement. If it's used correctly, people can get help from it. It's just not used correctly.
I agree.
Enough about that dark talk.
No, I was really just going to say, I didn't mean to pick on you, Bill. I just was really...
Okay, I'm used to it.
I was just going to say that when I tell recovering addicts that my son is on Vivitrol, a lot of their attitude is, that's a cop-out. And that kind of makes me angry, because I don't think that you can put every addict in a box and say that NA and AA works for everybody, 12-step programs. My older son that died, he could not do NA, he could not do the 12-step program. If he were alive today, he may be able to have been saved by the Vivitrol shot. I don't know that. But I do know that my younger son is on the Vivitrol, and I don't care that he's on it. If it saves his life, it's not addictive. Why not? They have medicines that help other diseases. I mean, you take medicine for your asthma, patients take medicines for their heart disease, patients take medicines for Parkinson's disease, patients take medicines for diabetes. Why can't people take medicine for addiction? It is a disease. That's all I'm saying. And I think everybody should have the opportunity to decide whether they want to be able to use that tool to help them, because it does give them the time to clear their brain so that maybe the 12-step program will work for them later on.
Therapy, like the great therapy that Elaine gives?
Or the great therapy that Elaine gives. I don't know Elaine, but I think she gives great therapy.
And just let me say, on the funding issue, it's the same thing. It only allows 10 days for rehab when you need 6 months. It's the same system. And that's what we're fighting. That's exactly that concept of not paying $600 some dollars when it could be.
You're talking inpatient. Most of the commercial insurance and the medical assistance insurance providers will cover intensive outpatient for months and months. And I'm talking partial hospitalization can go for, which is 5 days a week, 6 hours a day. A lot of them will go for maybe 4 or 5 months, and then they'll go down to 3 or 4 days a week. So commercial insurance, and I wish Mr. Tennis was here, he's absolutely right. You need to have treatment centers that follow the PCPC, which is the guidelines by the state. So he's right on track, and I wish he was here. If you are state licensed, and it's difficult to be state licensed because you have a lot of rules and regs to follow, and providers sometimes don't want to follow all those rules and regs. My family is in treatment because of our family tragedy. However, having said that, we want to follow the rules and regs. How would I want my son to be treated? So we do follow those. So you would be surprised, as an outpatient, you can get lengthy treatment. The inpatient, you may get 28 days if you fight for it. But what we have to do is coordinate the care. You get somebody inpatient and immediately get them into outpatient. And you keep them in outpatient as long as you can. Problem is, the patient starts feeling better and they don't want to come back. So somehow we have to mandate that that patient has to stay there.
Well, bond would do that.
What's that?
Bond, if they're out on bond and they don't go back, they go back to jail.
I think it's awesome that the law enforcement and the medical team is working together, and I can only imagine how hard your job is also. So thank you.
Okay, we have another question.
Yeah, I've done several research projects on Suboxone in general, and I agree with the Suboxone program, and I agree with what you stated. If Suboxone is used properly, it's a well-rounded drug. However, with the Vivitrol, maybe you can enlighten me, is I understand it's non-addictive, but what are you going to do when you get off of that? Are you stating that you're on this forever, or I understand it's a blocker, it's going to cover down receptacles in your mind, but I mean, is there a time frame? Because I thought
We don't know. We don't know. To be honest with you, we do not know. No one's researched that topic. But I think Lucy hit upon it. Some people have high blood pressure, on blood pressure medicines the rest of their life. So I'm not saying someone has to be on it the rest of their life, but it seems to be something that's very effective in the early stages of addiction and enabling someone to get rid of the craving so they can actually seek out and really sink their teeth into recovery. So we're learning more and more. I think Lucy and down here at Uniontown in my office, we're using a lot of Vivitrol, and we're collecting data, and we're starting to understand how to best use it. But right now, we don't know. I've read one little thing, it said 2 years, but we don't know. The thing we look at is if someone's on Vivitrol, they can't just be on Vivitrol, they have to be working recovery. But if someone's on Vivitrol and doesn't want to do recovery, we don't say, okay, we throw you off.
Okay, so they're mandated to go to some form of NA or AA meetings or counseling up there?
We actually, I'm with Jade Wellness, and Dr. Wolfhammer is with Fayette County and works with Jade Wellness. You absolutely have to be in therapy. We're not going to give you a medication and not address all your other issues.
So you absolutely are in therapy, and then if someone wants to do AA or NA, they do that. The other thing, there's no withdrawal when you come off of Vivitrol. Whereas Suboxone, it's a tough, it's addictive, and we have to go really slow when we taper someone off. Really slow. But there's nothing when you come off of Vivitrol. And Brendan?
Yeah, I am still on Vivitrol now because for my family, Vivitrol means that they don't have to take my word for it. You know, like they know I'm not going to get high, and believe me, I've lied to them for a very long time. So I don't have a problem being on Vivitrol because if I never get another Vivitrol shot, that's not going to affect my recovery at this point because I've done the work I needed to do. It also doesn't hurt me to be on it though, and so that's basically what it comes down to for me. Like right now, I'm more than willing to, if that makes my family happy after all the stuff I've done, I'll stay on it forever. But I'm past, it's sort of like if you learn to ride a bike, you use the training wheels, and after a certain point you don't need the training wheels, but you can leave them on, you know? That's sort of how I look at it personally.
The insurance coverages that do cover Vivitrol, I think all require active therapy treatment going on, and they're going to monitor that.
As they should.
Exactly.
As they should. I know UPMC commercial, they will definitely cover it for a year, but it's a new medication, so we're learning what happens after that. But we won't provide Vivitrol at our licensed facility unless you're engaged in therapy, and we do urine testing. It's all about recovery, learning the coping skills and everything else.
Here's, now is there a requirement to before you get on the Vivitrol shot? Do you have to be clean for X amount of time prior to? And if that's the case, how do you get them clean? Do they start out Suboxone, then you wean them down, and then they go into the Vivitrol?
I could talk to you for 3 hours on that. The art of working with Vivitrol is how you get someone from the opiate to the Vivitrol. The half-life of the opiates are involved. We try to use just non-addictive medicines for short periods of time. A lot of the people at the clinics I work at, we have slow detoxes, sometimes with Suboxone over several weeks, and then we stop that, put them on comfort meds or transitional meds, and then get them to the shot. But it's a real complex question because everyone's sort of individual.
Right.
And we have even some people, we push the envelope a little bit because, you know, you get a little early, you may get sick, but they're thinking like, you know, I'm going to go out and use heroin today, I'd rather maybe get on the shot today rather than and be a little sick. So it's a complex question. But we're figuring that out too. We're getting better and better at doing that and even picking out what time frames from each opiate because they're all different. So the last one you use is really different. And what medicines seem to work best because we keep a computer program and all this, and we get feedback from it and finding out what combinations of transitional meds we're using seem to work the best. So that's an ongoing thing, but we know so much more now than we knew 2 or 3 years ago on how to do that. Now the literature says 7 to 10 days, and that's sort of a blanket thing we cover. That's probably the safest thing to say, but we look at that and say some you can do less on some opiates, some you may have to go a little longer on. But it's a good question, but it's a real complex answer.
Now, do you see it changing in the future for inpatient rehab centers? So instead of them using a detox form such as methadone or Suboxone, do you see them ever going to a Vivitrol shot so that way they're never ever...
What we've been encouraging rehabs to do is to, when you leave the rehab, to get a shot. And that some of the rehabs gateway and some are offering that. They're not saying you have to do that. But like so many people I talked to when they left rehab, within an hour or two of getting home, the cravings were there and they went on use. So it was sort of like, and then they went back to rehab. That's why 8 times, and it can be like a long, exhausting process. So that at least gives them a chance to not have the craving. A lot of times they leave wanting to be clean, wanting to go to meetings, wanting to get better. But the cravings come on, and someone calls them on the phone or texts them, and they're out the door.
Thank you.
How many people Fayette County right now on Vivitrol? That's not a HIPAA violation, right?
No, it's not a HIPAA violation. I don't really know. I would have to have thought about it, but I would say that. What would you say, Elaine? What do you think? Because just what we work with, because I know there's other people, I know some people come up to my office and some go to Jade, so. Yeah, it's not many, no. It's very underused medication, not that it's a cure, it's the answer to everything, but it's a great tool that's really underused.
It is much cheaper than heroin addiction. I will say that. $640 a month is a drop in the bucket in comparison.
Or the 8 burglaries that I had.
Or that, yeah.
Prosecuting, and they probably have about 2,000 that they got in each burglary.
Or the cost of a funeral.
Okay, next question.
Hi, I'm Jamie. I'm a recovering drug addict, almost 9 months clean also. And I feel big props to the Vivitrol and Rivia. I just got off Rivia 2 weeks ago. Rivia is the pill form of Vivitrol. Unfortunately, because I got my family in such a financial situation, we could not afford the Vivitrol. So therefore, my insurance company didn't pay for it. I had Blue Cross Blue Shield. So my insurance company did cover the $15 for the Rivia. My husband watched me take it every day. He made sure I didn't cheat it, which is when we hide it in our cheeks and spit it back out in the cup. So it is a shame that these big insurance companies aren't covering it. I mean, my addiction cost me $400 a day. You know, I was shooting a brick of heroin a day. And it's a far cry, like she said, for a life. I mean, the price of a life. But unfortunately, some families, we cannot afford it. You know, I had a job of 22 years. I lost making $65,000 a year due to my addiction. And I got us in such a financial situation that we're still trying to climb out of it. And we just couldn't afford it.
You climb out of it.
Yeah,
There's
we are.
something else that I'm glad Rivia worked for you, and that's incredible. But there is a difference in how the Vivitrol and the time release works. And it works much better than the Rivia, but I'm glad the Rivia worked for you.
Yes, it did.
Because there is actually a period of time during the day that your opiate receptors are not covered using the pill form of Rivia. So there is reasons that we want people on the time release.
Right.
There's reasons, not just because of convenience.
But it
I'm
wasn't just
glad
the
that
Rivia that kept me
worked for
clean
you.
though. It
I'm
wasn't
so
just the
glad.
Rivia. I mean, today I went to 2 meetings. I go to meetings every day. I do work a 12-step program. I do have a sponsor. You know, I do the 6 things that we're supposed to do. The Rivia was a tool. And thank God for the tools that we have today. It was an extra tool. I did not have the cravings. They put me on the Rivia right before I got out of rehab. Like a week before I got out of rehab, I went to Gateway for 28 days. And they put me on the Rivia 1 week before I got out of rehab. So, well, thank you. Even though I gained 30 pounds clean, I got 30 pounds to lose now. But
Excellent. The way you said that is perfect. That's it, just a tool.
And that's what it was to
Yes,
me.
exactly.
And my husband actually wanted me to stay on it for a year. And when they gave me the prescription when I left the Gateway, it was only good for 6 months. So at the end, I tried to taper myself off of it because I wanted to try to make it to that year. And he's like, why don't you just call Gateway and get another prescription? But I feel comfortable enough with me working a 12-step program with a sponsor. I felt well enough to come off of the Rivia. And so I've been Rivia free for like 3 weeks now. And it did work.
Okay, next question.
I would like to say first, I like the idea of the monitoring program. I would like to ask, I don't know if anybody could, help me. Like, I deal with addicts daily and it gets very draining. I wonder, what channel you would go through to report someone abusing. Like my roommate is, it's not unusual for me to go home and find him passed out with his trying to put his sweatpants on his head and have 2 different socks and the oven on with an empty skillet and just out of it. And I've called everyone. I've called drug and alcohol. And he's on the methadone program. And he has told me the counselor will give him an extra dose and say Merry Christmas. And he will trade it. I've seen him go to 5 different doctors, 5 different pharmacists, get prescriptions, or trade his methadone for Klonopin. I've called 911. I've called, the drug and alcohol, everyone I can think of, the doctors, the pharmacies. I feel like I'm humiliated. They laugh at me. They go, "What do you want us to do?"
Let me just say that you can't report those kinds of things to us because obviously, he's getting this somewhere, okay? And you know, sometimes this is a good opportunity where law enforcement can get involved, not to arrest the person, but actually to try to get some type of treatment for them. And sometimes we actually have to arrest them to try to get them in the treatment.
I've called the methadone clinic to report it. They said we can neither confirm nor deny he's a patient. I said, you do not have to. I'm telling you he is. Because they don't want to listen.
It's not in their best interest to listen to. They're making a lot of money.
Have him call us. Have him call us. Doc will do something. Have him call us. I promise. We will help you. We will help you.
The big problem from what I hear you saying is the issue of willingness. And I very recently was at like a town hall thing where somebody just like you was talking about this guy's sister who had a horrible heroin addiction that she did not acknowledge existed, and it was clear to everybody else that, you know, it was a big problem. And they asked me the question that you're asking now. And like I knew a kid whose mom had him involuntarily committed to Western Psych about 100 times, but she had to lie in order to do it, and that's a very, you know, difficult process. I mean, the problem is that for me, I was not gonna get sober and get clean until at least a part of me wanted to. And before that happened, like some pretty negative events had to occur in my life, and I'm very lucky that they didn't kill me. I don't know, what you're asking really is like the $1 million question. Like, how do you get all of this stuff is dependent on the addict having at least some desire to acknowledge that they're an addict and to want to change. The only thing that worked for me when I was like that, honestly, is losing friends. I wound up having a friend who told me, like, look, I don't want to be around you anymore. You're an embarrassment to me. And all the lies I had told myself about how, you know, not bad I was doing, I couldn't pretend that was something else. I lost my friend and he wasn't the only one. So that sort of broke through to me a little bit. But yeah, I mean, like Elaine said, definitely you can call. There's like you can Jade Wellness Center is very good about. They have a lot of different resources and they can talk to you about this. There are Nar-Anon and Al-Anon meetings. There are a lot of resources. I can tell you about some of them after this, actually.
Okay, next question.
My question is basically, is a person safe to drive, or are they even allowed to drive under controlled substance, even if it's at the lowest dose that they're given?
Let me just say a couple things. Well, first of all, as far as safe to drive, you know, any type of substance, you know, that can impair your ability to drive makes you unsafe to drive. Now, one of the problems is that a lot of times a person doesn't realize that what effect that this particular thing that they're taking has on them. You know, if we talk about, you know, it's kind of hard to answer the question because I don't know what particular type of drug that you might be talking about. But sometimes even small doses of drugs can affect your ability to drive safely. So if you're impaired to the extent where you're not driving safely, then you can be arrested for driving under the influence.
If it's in your...
Yes, if it's in your system, you're driving and you're not driving safely, and generally the reason that people get pulled over is because they're not driving safely. The officer observes their driving habits, and that's the reason why they make a traffic stop. So right off the bat, you know, that usually means that the person is under the influence to the point that they can't drive safely.
So, like with oxymorphone, is that...
Absolutely. You know, if you're talking about, you know...
Even at the lowest dose, does
yes,
that still have an effect on you?
Yeah. The things can, and there again, different people react differently to the medications or drugs that they take.
Even if they've taken it for 8 years?
Oh, yes.
Because under a doctor's supervision with pain clinics and so
But I
forth.
think those medications, they would say, go out. Right.
They do, yeah. Don't drive an automobile until you're aware of how it affects you.
Well, how do you know if you're aware of it?
Exactly, yeah.
You're taking it.
Exactly.
What if you've taken it for 8 years and never had a problem and you always drove safely on it?
Well, you think you're safe, but actually, I would say that you're probably not, because there again, an impaired driver often doesn't recognize that they're impaired. So what it means is that you might not have gotten stopped. You've been driving under the influence, but you may get stopped because of your driving habits, or worst of all, think about going out and causing an accident, hurting, killing somebody else because you're under the influence. Okay, now we're into a whole different ballgame.
That's also driving recklessly.
What's that?
That's also driving recklessly and being...
Right, and you're driving recklessly because you're under the influence of something. And that's the whole issue.
And then I'm prosecuting you for homicide by vehicle while you're high, and you're looking at a mandatory minimum of 3 years in jail if you kill someone.
So if you have anybody who takes any kind of basically pain medication, you're saying basically just sit at home and don't go anywhere. Don't work, don't go anywhere. Just sit at home because you can't operate a
Well,
car.
first of all, if you're under medication, you should be under a doctor's prescription and a doctor monitoring you.
Yeah.
Okay. And if the medication that you're taking says don't drive, then don't drive.
It doesn't say don't drive.
What's that?
I mean, it doesn't say don't drive. I mean, you're saying...
If you're under a medication where you're not supposed to take the medication and drive, don't drive. Because the risk is everything we said. Okay. Number one, you could get arrested, but worst of all, think about the other people on the highway.
Oh, yeah, I understand. I'm saying I have a clear record of, no DUIs, no this, no that, no impairment, this, that. I totally get where you're coming from, But it also affects people in different ways, and if you're abusing things in different ways, being irresponsible in different ways. If you're dealing with anything that is any kind of narcotic, anything, you have to be so responsible, beyond responsible. If you're not, then it can sway you back. You understand that?
Yeah.
Did you want to ask anything?
Yeah, in say when you take a urine test and it shows in that.
Like a rapid test.
Yeah.
A rapid test or rapid doctor.
Well, yeah, I mean, drugs can't show in a urine test. They could show in a blood test.
Yeah. What he wants to know is bowel checking. Basically, all drug tests will show positive and negative of what you have in you. But next to it is the NG and ML, which is the nanogram and milliliter. And all that really is, it shows a high number like 60,000. It's just showing how much it had to show that drug was positive in you. It's not showing that 60,000 is bad on you. It's showing that they had to show that to show that it was positive.
Now, there's laboratory results, and then they give us what those nanograms mean.
Yeah, it's really for lab. It's the NGLG or NGML is lab stuff.
Right, but they also have an analysis that a forensic scientist gives us to indicate what the ranges are and at what point impairment becomes something that we're going to arrest for as well.
What you need to do is talk to your doctor. Get an experienced doctor. If you need to take pain medication to get to function, you need to talk to your doctor about what levels. There's different prescriptions, there's different time release that might be able to allow you to safely drive or operate machinery. I have many clients that are injured. They're going back to work, they're working, they have pain. They prescribe some pain medication. They have to deal with that issue. That's where an experienced doctor in pain management can come in and can prescribe the particular medication you need in the particular form.
Yeah.
And a lot of people take it at night, so that I see
Yeah,
clients
that's
that do
what I
that.
take it.
There's a way to deal with that problem, but you need to deal with it, because if you don't and you are impaired, Steve or some other officer will arrest you for DUI.
Well, if I may, I think that what I'm getting from your question is, if I take a pain pill for an existing condition, chronic pain, that's a small enough amount that if it's having some kind of effect on my cognitive functions. It's very minor. And I get pulled over and they drug test me and I test positive for it. Can I get a DUI in that situation?
As Steve mentioned, it has to be to the level that it impairs your ability to safely operate the vehicle. Just the presence of it in and of itself is not going to be enough.
Thank you.
And there, as I said, there's lab results that we get that would indicate what level it starts as far as impairment. Now, they're rough guys, I agree, but nevertheless, they would be able to testify in court that at that level there's impairment.
I've been with the same person for 10 years. I take one thing, one item. I'm not on a bunch of stuff, but one thing, because I have all types of horrible back issues, just CP or whatever. So I do take it at night. That way it's not really affecting me in the day and all that. So I mean, so that's good advice and what y'all were saying. So
Well, he wants to have a life, otherwise he wants to be able to get a vehicle so that he can go and look for work and he can support himself a little better, or at least pay for some of his support.
Really my main goal.
My concern was, is it safe enough to get him a car to drive, because I'm concerned that, is he?
I mean, a lawyer would probably
Does a
understand
urine
that,
test
right?
kind of help decide that for you?
No.
No, the doctor, it's a medical question. What medication can he safely take that would keep him from being able to...
It's pretty hard to tell, though, when you don't give me a release. No, I can't tell other than when he's telling me.
Well, I gave him a drug test and it showed everything that I was on, and they just did that for him, no problems. And I've been taking the same thing for 10 years, and I haven't had any issues and no problems, no weird stuff. So it's one of the best info I can give you.
Okay, we have any other questions?
I just have one comment.
Can you come up here, please?
Alrighty. Hey, this will be interesting.
I'm the mother of a drug addict who has been in therapy for about 4.5 to 5 years with Dr. Woolhandler. And I thank God every day for him. He's on the Vivitrol injection, get it every month. I go with him every month for my own sanity, just to know that I got it. It's just me, but Dr. Woolhandler, I've got my son back.
I'm rocking that.
And,
Hey, you like that? That was rock and roll. I wanted to sing on that mic.
he's a terrific doctor, I mean, not only for my son, but for my own well-being as his.
We had go back to 2.5 years.
But you can change,
And yes.
and I try, friends that I know of his, I try on a personal basis to get to those people. Sometimes you can't, but the Vivitrol is not known, and it has to be brought to the public. It's a wonderful drug. The only side effect that my son has is sore lips. But other than that, no. And his insurance covers it. We pay the $20 a month copay, which a life over $20 or whatever is nothing to us. No.
Okay.
And I thank you.
Thank you very much. We have any other questions?
I have other law now. And I know everybody's tired of seeing me, so probably conscious of that. It's not to say, first of all, as a mother of adult children, my heart goes out to the mothers of lost children and to the other mothers and parents who are suffering because their children unfortunately are addicted, and I thank God every day my children aren't. But I also want to call attention, Mr. Hennick's mentioned all the crimes that are attributed to the drug use here in the county, the burglaries, the thefts, DUI crashes, but everyone in this room, and it's been said earlier, that we're all responsible as a community. And this is true, and it's especially true that we're all responsible for the children in this community. who suffer because their parents or guardians or whomever they may be are unfortunately addicted to drugs. They suffer physical abuse, they suffer sexual abuse, they live in deplorable conditions of which they have no control over whatsoever. And as someone also mentioned, we need to be the eyes and the ears of not only our own family and be interested in what goes on, but in our neighborhoods and to the people living on our streets and near us. If you think there is something a little funny or suspicious going on in a home or whatever, you think children are in danger, you have a duty and responsibility to report it to someone. Even if you don't want to report it to the police or law enforcement right away, there are organizations that you can report it to, who they will take the lead in reporting it to the law enforcement people and the people who can investigate and make sure that these children are safe. And as I sit across from a friend of mine who is also a co-worker, and Mr. Hennick's mentioned as well, and maybe Mr. Hennick can just touch on it for a moment, but we do have to have a responsibility to the children in this community who unfortunately suffer because they are in homes of whose parents or whomever are unfortunately addicted to drugs of some type or alcohol.
And I agree completely. In fact, I spent my day, I'm going to go back tomorrow to the maltreatment conference at Children's Hospital for children. And as Linda said, that is something that has certainly been near and dear to my heart for a long time. I was a child abuse prosecutor back in 1996. And when I started, and I see the ravages that addiction creates in those families, not only what I alluded to before about the common thefts. I didn't even say anything about domestic violence that leads to assaults and aggravated assaults, not only on children but on spouses and significant others, girlfriends, and so it goes through the whole community. And certainly Gina Diario was in the audience as well, who's the head of CYS, knows that as much as anybody does. So that's part of what we need to keep doing. And so whatever treatment that we need to do, we have to find ways to do it. And unfortunately, some of that when treatment stops or doesn't take place, that we have jail. And as I said, jail is certainly what people end up in, but it's probably the kind of the worst alternative and certainly the most costly to do that and probably counterproductive to a large extent. However, it's there because unfortunately we don't have those treatment facilities and we have to have some way of carrying out justice for people that are wrong, and that's what we do by putting them in jail. But I agree is that we need to end it from that standpoint to protect the children of Fayette County as well as the Commonwealth.
And John, I would just chime in on that just very briefly, that is another diversion, because if we become involved with a family because of addiction issues, we are going to attempt to engage that family and help them and empower them to get to treatment. Ultimately, as many people have said tonight, it is that individual's choice, but we will show them the door to treatment so that their kids can be reunited or remain in the home. So that is another diversion tactic.
Okay, I think that's been a
And I am one of those people. Our life is hectic, but
What's his name?
His name is Brandon.
Hi, Brandon.
But she is, I mean, that place is wonderful out there. I wish we went to some meetings. I wish there would be meetings where parents that have overdose. They need to have support groups for that. Because we have nothing.
Okay, well, I think that's going to conclude our program for tonight. First of all, I want to thank the panelists. I thought the information presented was very knowledgeable and shows a lot of caring and compassion on the part of all of our panelists. And so let's give all of our panelists a big hand. Also, we want to thank the good folks at the Fayette Drug and Alcohol Commission for having the forum, also the Penn State people, and also our local officials that showed up here tonight.
And one thing, because Mark won't take credit himself, we want to thank the newspaper for giving a tremendous amount of publicity to this problem in the last several years. I did want to say that I'm the editorial page editor for Herald-Standard, and we have been doing a series of stories, and I hope that people do follow them. And if you have any comments or any suggestions or any ideas for anything that maybe you think we should look into, we certainly are more than willing to listen and to try and work with the community. So I think that wraps it up, and thanks for everybody.